distinguished guests, esteemed faculty members, delegates, and students to VIROQuest 2026. The CMV's theme of Decode, Diagnose, Defeat reflects our collective commitment to understanding viral diseases, advancing diagnostic capabilities, and strengthening our response to both existing and emerging infectious threats. We are living in an era where viral pathogens continue to challenge healthcare systems worldwide. From endemic infections to newly emerging outbreaks, the need for scientific collaboration, innovation, and preparedness has never been greater. Today's CME brings together some of the country's most distinguished experts who will enlighten us with their knowledge, experiences, and perspectives on critical developments in virology and infectious diseases. We wish you a wonderful day ahead filled with enriching discussions, meaningful interactions, and valuable learning experiences. And now, without any further ado, we'll move to a scientific session. We begin with a highly relevant and important topic that addresses one of the major public health challenges facing our nation. The topic is towards elimination of viral hepatitis in India. Where are we now? To chair this session, it is my honor to invite Professor Ajay Duseja, Head of the Department of Hepatology at PGI Chandigarh. Dr. Duseja is a renowned hepatologist with significant contributions to liver disease research and clinical care. As the next chair, it is my privilege to invite Professor Varsha Gupta, Head of the Department of Microbiology, Government Medical College and Hospital, Chandigarh. Professor Varsha is a distinguished microbiologist, researcher, policy advisor, and has over 250 publications to her credit. Next, I would like to invite Professor Ashish Chaudhary, who is a renowned virologist from AIIMS, New Delhi, with expertise in HIV medicine, viral hepatitis, and emerging viral infections. May I now request our speaker to please come on stage? May I now request our esteemed chairpersons to kindly introduce our speaker and initiate the session.
Good morning to all. The first session today begins with Professor Ekta Gupta's talk on elimination of viral hepatitis. I think Dr. Ekta needs no introduction. In fact, when I finished my MD from AIIMS and I was doing my SRship, I was the first SR in ILBS. And it was just this beginning of ILBS at that time. And I saw ma'am struggle for that lab. And now it's a wonderful lab and she has done wonderful work. And she continues to inspire all of us. So ma'am has more than 150.
My slides. So very good morning and thank you, chairs, and thank you, Department of Virology, PGI, Dr. Rathore sir, Mini, for giving me this opportunity.
Okay.
Yeah, so I'm the opening batsman today, and topic so close to my heart, but may not be that close to others. So we are talking about towards elimination of viral hepatitis from our country. Where are we now? And I bring greetings to you from our institute. It's a dedicated institute of liver disease. So I'll be talking about what is the, these are the heads under which I'll cover. What is the burden, global and Indian? We have a national program. What does the hepatitis global WHO report says? What are the important gaps and challenges? What are the problems? And what virologists should contribute in actually elimination? Yeah. So I'll not use a pointer. So the global concern for hepatitis B and C infection rose in 2016 when this report came. And it showed clearly that chronic hepatitis B and C, from where is this pointer coming? I don't know. is more than tuberculosis, HIV, and malaria. And that is why the SDG goals were decided, which WHO said by 2030, we have to target for 90% diagnosis, offering 80% treatment, and reducing the mortality associated with viral hepatitis to 65%. Next slide. Yeah. So these were the targets laid down, and as you can by those SDG goals, and as you can clearly see that what was the baseline level in diagnosis was just 9% for B, 20%, and we have to reach towards 90 for all of them. Now, in response to this, in 2018, and a lot of contribution from our institute as well as the entire gastroenterologist community was there in launching this program. And but still, India ranks second globally in the number of viral hepatitis cases. Nothing we have to be proud of despite an active program. And it contributes significantly to cirrhotic and liver disease as well as liver cancer. B is there in the rural population. HCV is still there. And unfortunately for children and adolescents, which is an important problem, we are not doing anything. And still there is a high burden in high-risk groups, which is there. So this is the global hepatitis report published in 2026. And as you can clearly see that, as you can clearly see that definitely diagnosis is the one where we are lacking. How many are actually there and how many percentage we are diagnosing and how many is getting treated. And surprisingly, this, despite being such global active efforts towards elimination, it is one disease where the mortality, WHO itself globally rose. I mean, despite such active, we were hoping that it will decline, but as you can see, the number of, So this is a publication, Dr. Duseja sir is also there. We are a WHOCC and a collaborative publication where ILBS and the other centers have shown that what is the contribution of hepatitis B and C in causing cancer, cirrhotic as well as non-cirrhotic. So the emphasis is that even without damaging the liver by the progression of liver disease, B and C can cause HCC even in the non-cirrhotic, even in asymptomatic cases. That this is what we want to highlight here. So so what are the leaks or what are the gaps? So we started this National Viral Hepatitis Program in 2018. If we go by what is happening, although it's a lot of praise for our country that they could open so many centers and made these things available, the card test and the treatment option, which was not there. But still, to reach the target of 2030, I think we need to do more. We need to accelerate more efforts, at least in few institutes, right? Yeah. So what are the leaks? Where are we lacking behind? So I could actually think about three leakage. One is that underdiagnosis. Definitely. We need to gear up the microbiologists to take up virology, to start virology labs and move away from just HIV to viral hepatitis testing. And not only just HBsAg, NTHCV, viral load, the other markers, so that the clinicians can put the patients on treatment. So underdiagnosis is one important leak. Then comes is the attrition. So the patients are not put immediately into the cascade of care. What happens is you diagnose and they never turn back. So one has to look for how to retain these patients into the cascade of care so that the problem needs elimination. Third is the workforce. So there are definitely the advanced liver disease or the complicated viral hepatitis cases requires a gastroenterologist. Sorry, sir is here. But we should shift the task force of uncomplicated cases to non-specialized worker force. These are very good management guidelines are available for BNC. At least those treatments should be initiated in the rural areas by non-specialist task force. So task force is also important leak. So underdiagnosis. So what are the current practices? I try to make a table and what more needs to be done. So patients, normally we are testing for hepatitis B and C, sometimes A and E, when the patients come with abnormal liver function test. So when the liver function gets, so these are symptomatic cases, and then you are doing clinician-based testing algorithms. What we need is that we have to expand this to general population. As I showed you, that hepatitis B and C can even cause HCC in those where non-cirrhotic. So the liver may not show you abnormal LFT, but virus will replicate and lead to the harm. So we have to shift our practices to general population. We have to, rather than clinician-based testing request, lab-based reflex testing. So lab should know HbSAg positive, what next to do, what to do, and what to advise. Why can't people who are done MBBS and MD microbiology tell the patient that you require treatment, you don't require treatment, you require this investigation. So we need to step up our approach of microbiologists doing a lab-based reflex testing. We need integration. So you have microbiology setups, the virology, HIV lab is separate, viral hepatitis lab is separate, TB lab is separate. So we need the combination, integrated testing approaches, need the multiplex kits. The HIV person can do hepatitis, the TB person can do hepatitis, the syphilis person can do. So needs integrated approaches. Also the involvement of the private sector, which is lacking right now in our control program. Actual footfall of many patients goes into these private sector labs. So just involve them and educate them about this program. In blood banks, routine serological testing is being done by HbSAg and anti-HCV. We're just doing that. But we need to, if you want more cases to be, so you have to shift from the RDT, the rapid card test approaches, to more convinced ELISA or CLIA-based or NAT testing, because you will pick up more asymptomatic cases from there. Unfortunately, the card tests which are available in our country has got a very, very poor sensitivity, and we need more sensitive, better card test or employment of ELISA techniques or NAT testing. There you will book. Then the blood bank should not only test and discard the blood bank, they should do a donor recall and also do a family screening. So their story ends with the donor. If HbSAg or HCV comes out, they have to do the family screening. They have to tell them what is the problem with them. So this can be done. Pregnant female screening, why B only and not C? I just don't understand. Because if it is causing the same kind of a problem from mother to child transmission, we have to expand the testing in during ANC to HCV. And again, there, those who are taking care, they should do reflex. Quantitative NAT testing, should advise about the perinatal testing. If antiviral needs to be given to a mother and then stopped after birth, then that should be done. This is one important area microbiologists can take up, or gynecologists can take up, or the neonatologists. They should start screening more. Family screening of an index case is very, very important. We at ILBS is emphasizing a lot because it runs in the family. So you have an index case, you have to counsel them, you have to do an extensive, not only mother, father, siblings, wives. So the story should not end with the sexual partners. It should start with the entire family, and then you should advise them and put them onto the cascade of care. So this is a few strategies. CDC in 2023 has adopted this 3-test policy mandatory. And I really want to highlight that they are achieving. So what they do is that at least once all adults more than 18 years, they should be tested for HbSAg, anti-HbS, and co-total antibody together. Now, what advantage they are getting is that here, by this triple testing, you're picking up cases, and you're also picking up those who have, with the underlying any other comorbidity. So the fatty liver, the MASLD, the alcohol use, all are damaging to the liver. And subsequently, if you have this viral hepatitis damage, it can lead to a lot of progression of the liver disease later on. So by doing a co-total also, what you are doing is that you're identifying these adults if they have ever been exposed to, and then if they require a booster vaccination or a catch-up vaccination, then that should be offered. And in case they require some immunosuppression later on, on, then they can be advised regarding or they can be given prophylactic antivirals to prevent the reactivation once this occurs. So this is a very important step our government can adopt to triple test by not relying on the core total also as a marker. The public health, so we have to focus now, move from public health to person-centric approaches. So one size fits not all, does not fit all. So you have to take care of now individualized testing approaches, decentralization, integration, task sharing. I'm sharing this. Point of care testing devices should be there, whether they are good RDTs, which are highly sensitive and specific, or you have the point of care nucleic acid testing. Reflex testing approaches should be lab-based, clinic-based also, but preferably lab-based. And then those far out places where it's difficult to obtain the samples. So dried blood spot sampling can be done. They can be connected to a centralized lab, and healthcare worker, utilize the peer and lay healthcare workers to support community-based testing efforts. And you can put the clinician reminders. The lab can do this, that, okay, we diagnose this. Have you put them? Have you called the family? So those approaches can be adopted, and so to improve the uptake of diagnosis in our country. So this was about what we should do to enhance the testing. Now, lack of newer diagnostic approaches. So we are still stuck with the same. 2018, we started do card test, do nucleic acid test, but why not the other approaches so that you can control? So the WHO has come up with, but we should make more efforts to get these things. The self-testing oral testing kit is there. Unfortunately, it is not available in our country. We should do efforts to get them. We have a lot of international companies, point of care viral load assays, but we should make in India and have actually affordable diagnostic test. Dried blood spot specimen for viral load testing, you should use them. You should start doing the diagnostic integration. And again, I'm saying availability of low cost, highly sensitive and specific RDTs if you're screening. This is the reflex testing for the students. What I mean by saying a lab-based reflex testing or a clinic-based reflex testing, ideally we should stress on same-day test and report. This should be because one positive person with a high viral load for B and C can go back home and can infect so many because of the horizontal transmission. So the labs have to gear up by doing batch testing or doing random access testing. They have to start reporting same day test and report by doing this, and then immediately informing the clinician and the patient also that what all they require further in the cascade of care. These are the near point of care molecules. So there are many devices which are available and they give good result. We have also evaluated them and started using in the emergency. I think we should make effort that these become affordable, and many labs are capacitated. The random access systems or the good where the systems where the extraction, automated nucleic acid handling system, so that you are not having a lack of manpower and you are giving the viral load results the same day. We have done a couple of evaluation at ILBS and we've been using these assays. In fact, one of the very good evaluation we did was using these dried blood spot between 3 sites, CMC Vellore, ILBS and Nari, Pune, and we actually collected the sample and transported to these far-fetched labs through the simple speed post, and we saw that the sample does not deteriorate, and you can use these. But if you don't have these assays available, you can actually use these method of transporting samples and getting the results. So this was about we should adopt to the newer methods and approaches. We should also start decentralized approaches and expanding the program. So what is the deadlock with these programs? We did this Delhi model, just like Punjab. This was a decentralized one-stop shop model experience, and we actually capacitated these mohalla clinics, 15 mohalla clinics, and those were the medical officers sitting there, and we could screen actually and show show the feasibility. We screened 30,000 patients in Delhi. These are 5 and 15, 20 sites we created, and simple medical officers. They could put so many on treatment, and actually we attained a good SVR rate of 97% in non-cirrhotic. So this was, so if we can do with 1 year, gearing up, active role of a microbiologist was there, but same can be done in the other states as well. Same day test and treat has actually done wonders in Egypt. We are talking about following the Egypt model. So they again emphasize same day report, test and treat. That will be the way forward for elimination of viral hepatitis. So we have to adopt these decentralized and same day reporting and same day test and treat. What right now is just, I wanted to tell that this is a national program guidelines. We are depending upon getting an HbA1c done. What are the lacunae here? The report goes to the patient. Then he approaches the gastroenterologist again, or a medical officer. Then they assess by LFT, by ultrasound, or FIB4 or fibroscan to know the fibrosis. You don't treat all. You treat only where a DNA is more than 20,000, cirrhotic liver. So there are, you're not treating all of them. And all this cascade takes about 4 to 5 days. And sometimes patients, because they're asymptomatic, they don't even feel that we require medication, and the ultrasound is not working. The ALT, LFT will take more time. So you are losing on to the patients in this cascade of care. So the limitations of this is that treatment is not offered to all. And once the patient is diagnosed with DNA and the report goes after 7 days, the horizontal spread of infection is happening. Counseling to the household members, screening and giving them a catch-up vaccination is not there. Reflex testing. Treatment is only limited in our national program to more than 18 years, whereas WHO says get it down to adolescent and more than 3, we should adopt that. Antenatal and newborn testing and monitoring is not there. Unfortunately, they say that that is another program you should follow. And newer markers which are more reliable, whether as a treatment stoppage or evaluation of HCC should be there, and adult catch-up vaccination. So these are the latest WHO guidelines. Here they have said that even if the DNA facility is not available and you have so many, the column 3, presence of any of these, co-infection, family history, immune suppression, comorbidities, diabetes, mast cell, start the treatment. Okay, so it's not moving. So these are the conventional markers we rely on for hepatitis B surface antigen. There are newer markers also available, like quantitation of surface antigen, looking for RNA correlated antigen, which can guide you better. And we are evaluating few of these newer markers. It's not moving. So we have evaluated these quantitative surface antigen for the last 10 years, and they are better monitoring tools. And, getting down to a more highly sensitive surface antigen quantitation can be a better marker. We have also started evaluating the correlated antigen, HBV RNA. Unfortunately, very little companies are available in India. And we have seen that they exist. Those who are on treatment, DNA negative, they still exist. So these can be for a better monitoring marker or a stoppage rule if you want to start. So we should move towards more new markers. Yeah. So catch up of hepatitis B vaccination should be started. Start looking for those who have a comorbidity and they are not vaccinated. You can do at least the high risk healthcare person, lab person, they should be done. And make sure that all 3 doses of the vaccination has to be given, and the gap should be maintained if you have to start with the hepatitis B catch up vaccination. So this is the schedule you have to follow. In C virus infection, I'll be quick. B is more, which is challenging and requires So in C, simplified, it's a good virus and antivirals are given. The SVR is more than 97%, but you only need to involve the children and adolescent age group in this. Here, the screening is done by NT-HCV, and any RNA positive, we're putting them on treatment. you should actually, these are WHO guidelines, and where they recommend that at least more than 3 or 3 to 18, they can be also started. So our national program should come down to adolescent treatment guidelines for hepatitis C, because it is a problem there. And we should update our national program guidelines. We can do drug resistance testing in case there is no need with the pangenotypic in those you're putting on DA, but however, in genotype 1A, or at least as per ASLD guideline, the genotype 3, if there is a treatment failure in first, you are starting again there, you should give, not by looking at the drug resistance, at least the Y93H mutation, and then you should start for the newer drugs. So nothing much in C. I think we are up to the mark. Only thing is that we have to enhance the testing and put more and more patients on. And self-testing, WHO has come up with the self-testing guidelines. I think we should also make effort as a country to get these kits available and encourage more and more self-testing testing and put the patient on treatment cascade. Core antigen is another marker, but if it is available as RDT, then will be a good marker. Be on a lookout for drug resistance. If you have a treatment failure, you're not responding, still progressing liver disease, then RAS can be done only in treatment failures. Now, coming to another quick viruses like hepatitis E virus, the vaccine is there globally, and E recently we have seen can cause a lot of damage, especially in pregnant female or patients with pre-existing liver disease or comorbidities. And so apart from food and water sanitation that we are saying, this vaccination should be made available, and at least targeted immunization strategies should start. You have recombinant HEV vaccine available. We should do efforts to get this in our country and start using them with patients for targeted immunization strategy. A is the epidemiology is changing. We are seeing a lot of A-associated ALF and deaths in adolescent and young adults. We've been publishing, and we are trying that this virus also requires a catch-up vaccination, because if you're just focusing on clean water and food habits, no, at least start taking history and do this thing. Delta virus, again, although we have not seen, but whatever data we have is 10 years back or 15 years back. Now you have more advanced diagnostic tests available, so its prevalence needs to be redetermined in our country. These are the Liver Disease Association guidelines when they say, so we can also start Delta virus screening in our population. And so in the end, I conclude that prevention, testing, and treatment, all these three requires updation, and so that if we have to really move towards hepatitis elimination. I thank you all. Thank you so much.
Thank you, Dr. Ekta. That was really wonderful. I know there was a constraint of time, but that you've covered it so well. Do we have some time for discussion, Dr. Mani? Okay, maybe 5 minutes. So I think I'll just start with maybe some of the clinical relevance to this topic, and then obviously I think the virology part can be covered. So, you said that the WHO goal is to reduce the or increase the detection at least by 90%. Also, that the treatment should be available at least to 80%. And finally, the aim is to reduce the mortality related to hepatitis B and C, maybe to at least 60%. These are the aims. So we are obviously yet far. These were the aims initially for 2030. So what thing we feel is, and you can maybe comment on this, why this all got delayed. And one of the contribution could be that the COVID epidemic came in between. So we lost those 2-3 years in achieving these goals for sure, number one. But having said that, the national program is there. Punjab model came from here, and then came the national program later, and our department really contributed a lot in that. So in that, 2 or 3 things happened. One was there's something called as decentralized approach. Rather than only the hepatologists treating or the gastroenterologists treating these patients, we came up with this decentralized approach, and the program called eco program. And we started this eco program was where we were actually training the Punjab medical officers online and trying to tell them that time hepatitis C treatment was a little difficult. It was pegylated interferon based, and then came the DAs. So I think that decentralized approach is very, very important. The second comment I would like to make is about the, you mentioned about the WHO approach in 2024. Before that, even the Chinese came out with their guidelines. There's something called a strategy called treat all approach for
I
hepatitis B.
missed that slide.
So treat all is basically they gave it for those who are little resource constrained areas. In ASL, the Indian National Association for Study of Liver, last year actually we came out with our own guidelines. We did not completely agree with this because there was actually too relaxed kind of guidelines. WHO, somebody who's hepatitis B positive is inactive, doesn't have liver disease at all. Should we be treating everybody? I think that's a big question and is a point of discussion. But I think that's the second point I wanted to make. My last point, or maybe this is a question to you. As you said, and this is our paper in publication for last 12 years, that hepatitis A as a cause of, acute liver failure has really gone up. And not only as a cause, the mortality related to hepatitis A has gone up, but the E is kind of gone. In last 2 years, we did not see even a single case of hepatitis E related acute liver failure. This year we saw two. Both are fecal-oral transmissions. So what is the reason? And we know that the socioeconomic status has improved. That's why the E has gone down. But the A has gone up, but the E. So what are the differences between HAV and HEV? That the one is going up, both have fecal-oral transmission, both are related to your, socioeconomic thing and all. So why this little contradiction there?
Thank you, sir, for so I'll go point by. Yes, I agree. The decentralized approach was the Punjab model, and then following that only we did Delhi model study, and we also took the eco program help, and we trained. That's what I said, that mohalla clinics in Delhi, 20 mohalla clinics, and we could screen 30,000 and treat 800 HCV viremic patient. That was in 9 months time, and again COVID came. So decentralized, I totally agree for uncomplicated cases. Second is treat all. Yes, in our institute, Professor Sareen has been the spokesperson for treat all. And I agree that why let a virus remain inside an organ if you have antiviral? So treat all, but if you have a stoppage rule. Right. So you cannot treat all for lifelong. That's the adherence is a problem. But if you treat all and then you have a marker by which you can stop also the antiviral, that can be done. That is why I'm saying that newer tests like RNA, correlated antigen, or any other marker, we should start evaluating them. That can we look by something and stop also a treatment, and then the viremia is not there in them? Because if even in the phase 1, you say those tolerant phase, the viral load sometimes is 6, 7, which is, and they are not practicing the precautions of preventing the horizontal spread. So the whole family gets infected. Third is A and E. Yes, it's a dilemma that both the virus are fecal-oral, and actually nothing is related to virology or viral genome, which is making one more prone. Only thing is that A takes over the childhood. So it's more waterborne, and E comes later in the adult. But we have been seeing recently the cases of E-associated adolescent liver failure. In Delhi, in our institute, last 2 years, there was a decline. But from last year, December onwards, we are seeing a lot of cases of E, and E causing ACLF, ALF in adolescent and associated. Virology point of view, this is the only thing I understand is once A occur in the childhood, it gives you an IgG response, which is protective for your lifelong. And then it allows the other virus, E virus, maybe it is the replication is faster by the virus, but we've not looked into scientifically for this cause.
So just to add, I think when I was studying hepatitis in the beginning phases, there was this hypothesis of the receptor that the immature liver does not produce that protein which is required by E to enter
Okay.
into the hepatocyte.
Maybe.
But A, the protein is there since birth. We don't know. This was a hypothesis 20 years back. So maybe that's the reason why, despite being fecal-oral, E doesn't infect a pediatric liver
Younger.
that commonly. But what I totally agree with ma'am and sir that E has drastically come down. Just 2 days back, we had an 8-year-old child with acute hepatitis E.
Yeah.
Very rarely do we see an
Yeah,
8-year-old child
yeah.
to have hepatitis E.
We've also started seeing.
And as Sir rightly pointed out, A has become a big problem. We have had a lot of mortality
Yeah.
by HIV-related ALF in AIMS also. So I think that's one reason to start immunization.
Yes,
Although I
immunization.
understand that for the country, many of us are in childhood immunization would be a big cost. But then we lose children. In the government sector also, where transplant is not available, we have lost a lot of children in the government sector because of ALF associated with HIV. So I think it is prudent now. It's time to start vaccination.
So we've shown
That's
our data also. Adolescent A-related ALF had lots of mortality because their immune response is stronger. Children will not have, but as your immune response grows, these hepatotropic virus themselves don't cause damage. It is the immune response they generate. So more stronger immune response you have. So adolescent is the age where you have all immune responses very strong and ALF is there.
One of the hypotheses, this is again an hypothesis, as you rightly said, we really don't know that both being fecal-oral and the overall the socioeconomic status has improved. So why one is going up? So one of the belief people believe is that is it related to person-to-person transmission versus really the waterborne transmission? I'm talking of something related to the host, which are host factors, which could be responsible. And then we also keep, discussing whether they are really biological factors, the genotype or the serotypes. Do they determine that whether the HIV is going to be virulent or not? So I think, as he said, this is a work in progress. We really don't know. But I think this is a point which needs to be thought of.
A small comment regarding, as since a microbiologist is speaking, so reflex testing should be enhanced. Very, very important. One case comes to us as HBs antigen or HCV and antibody positive. We should do on our own. Start with the viral DNA load or going for HBe antigen testing, the core antigen. And once that will be of real help if microbiologists are doing that.
So just waiting for a clinician-based reflex testing, I think the lab-based approach.
No, absolutely, absolutely. And the WHO really supports that. Once you find that somebody is S positive,
You can order.
rather than patient coming back to us and we ordering antigen, DNA and all, you should be doing it reflexly. And I think then automatically you should come to us.
And a microbiologist can also refer them. So when a medical officer can treat, a microbiologist can also for uncomplicated. I don't find that.
And the use of rapid car tests at polyclinic levels, each level, so that we don't miss the patient. That is the point. Nice presentation.
Thank you very much. Thank you. Thank you.
May I now invite Professor Mini P. Singh and Dr. Kapil Goyal to please come forward and felicitate our chairpersons. May I request our chairpersons to please come back on stage. Ma'am. Thank you, sirs. Thank you, ma'am. Acute encephalitis syndrome continues to pose a significant diagnostic and therapeutic challenge, particularly in resource-constrained settings. Accurate and timely diagnosis remains critical for improving patient outcomes. Addressing this challenge, we now move forward to our second lecture of the day, Acute Encephalitis Syndrome, Decoding the Diagnostic Dilemma. To chair this session, it is my honor to invite Professor R.K. Ratho, Dean Academics and Head of Virology, PGI Chandigarh. Sir is a pioneering virologist, accomplished researcher, and an inspiring leader whose contributions have significantly advanced virology, diagnostics, surveillance, and public health in India. Now it is my privilege to invite our second chairperson, Dr. Anita Desai, former head of the department Neurovirology at NIMHANS, Bengaluru. Ma'am is a distinguished leader in clinical virology and global healthcare. Also joining us online to chair the session, we have Professor Amita Jain, Executive Director and CEO, AIMS, Raebareli.
Hello, everyone. Hello.
Thank you,
Hello.
ma'am, for taking
Thank
out
you for
time.
the opportunity. Thank you.
Thank you, ma'am, for taking out time from your busy schedule for the CME.
Thank you.
May I now invite Professor V. Ravi to come on stage and deliver his lecture. May I now invite our chairpersons to kindly introduce our distinguished speaker.
Okay, thank you.
Good morning.
Come up on the screen as well.
So we have the eminent virologist, teacher come virologist, also a selector for many of us, I think. So it is very prestigious to have him here on the stage, and also a master in the topic acute encephalitis syndrome, worked quite a bit and came out with different algorithms and solved many puzzles. And his topic will be very useful to everybody, because you have faced lot of problems those days identifying this etiology of this acute encephalitis syndrome, missing many more, missing the bug. Now we have something to tell about that. These are the possible agents which might be causing maybe a geographical variation to that. So thank you, sir, and let me invite you for the
Just Ravi, 1 minute. Good morning, everyone. This is really a rare opportunity for me. Okay, I have been Dr. Ravi's first PhD student, and so chairing a session where we had my teacher, delivering a talk is such a wonderful thing to remember, right? I mean, cherish a memory like this. So over to you, Dr. Ravi, for this lecture.
Thank you for your kind words, chairpersons, and hi, Dr. Amita Jain. Nice to have you online. At the outset, let me thank the organizers for inviting an old bad boy in virology. I'm no longer active. So when Professor Mini Singh asked me to deliver a talk, I immediately agreed. Then she said topic. I said, I don't know, you decide. And if you have friends like Minnie, you don't need enemies, because she gave such a complex title. I had to sit and really understand what is expected of me. So I've made an attempt. I've done away with all my old slides that I used to use when I was in IMATS. These are a new set of slides. What I will do in the next 25 minutes is to tell you about the dilemmas that are there in understanding acute encephalitis syndrome. To my mind, there are 4 dilemmas that I looked at it. One is the clinical dilemma. First of all, AES is, I'll tell you later on when I come to the definition, it's a very broad definition. Clinically does not point to etiology. Unfortunately, even today, there are many hospitals In the case sheet, the final diagnosis is acute encephalitis syndrome. Please remember, it's a syndrome. It only describes what kind of clinical presentation a patient is having. It is not a diagnosis. The second is an epidemiologic dilemma. Here we are trying to ask, where did this disease occur? What other things are occurring in the background? Is there an outbreak? Is it a sporadic case? And so on. And these epidemiological questions are very important when you come to the final diagnosis. Diagnostic testing dilemmas, I will dwell into it. What test to do, when to do, how to do, which sample. It's always a problem when it comes to a disease that involves the central nervous system, because half the time you don't have access to cerebrospinal fluid. And then, of course, the interpretation dilemma, where you don't know what a test result means, because you have only one sample and you don't have another sample that is very critical. For example, you have only serum and you don't have CSF, then how do you interpret the results? So the basic logic is identify the syndrome, map the epidemiology, choose the right tests, and interpret results cautiously. Moving on to the first dilemma, the clinical dilemmas. First of all, the definition of AES itself is so broad, it is designed for surveillance and not for diagnostic purposes. So if you are in a tertiary care hospital, this definition should only guide you to look for etiologies. It is not a diagnosis in itself. And this definition being broad, it incorporates a large number of CNS manifestations with or without inflammation. The dilemma of encephalitis versus encephalopathy. Is there an infection or is it a metabolic event that is driving the altered sensorium? And scrub typhus, all of you know, and I will tell you also later, it's one of the commonest causes of acute encephalitis syndrome in India now. Comes without an eschar. eschar is not there in more than 80% of scrub typhus diseases. And Dr. Amita Jain, who has vast experience, will vouch for it. And also, increasingly recognized new clinical entity in the last decade and a half, autoimmune encephalitis, which is not an infective event, but mimics an encephalitis. And so also certain metabolic and toxic illnesses which mimic acute encephalitis syndrome. The clinical principle is very simple. It's a syndrome, but the clinician must rapidly try to segregate whether it is an inflammation or a metabolic event and start treatment, especially for the treatable causes. As I said, AES definition, this is the WHO definition. In 2005, it was coined for surveillance purposes, incorporates a large number of infections and non-infectious etiologies. And I must add to this list the amoebic meningoencephalitis, which has become a regular event in several parts of Kerala in the last couple of years, primary amoebic meningoencephalitis. Encephalitis versus encephalopathy is very important. I think Ekta made a very nice point. Remember, we are all clinical virologists, and we should definitely ask these questions whether it is an inflammation or whether it is a metabolic event. You can easily make out the difference. Infection and with inflammation, usually there will be seizures, there will be fever, has to be there if it has an encephalitis. And then, of course, there will be increased cells in the CSF, a very important parameter that needs to be paid attention, and focal neurological signs. And of course, in the last 2 decades, imaging has become very, very accessible. So CT scan and MRI will tell you if it is an infection or an encephalopathy, because there'll be a distinct neurological lesion. Metabolist encephalopathy, on the other hand, usually you will have other signs that you have to look for, mainly low blood sugar, hepatic involvement, renal involvement, sepsis associated with encephalopathy, low sodium associated with encephalopathy, and also in certain instances, toxins and pesticides can also produce Rett syndrome like picture confusing with diagnosis. Now, scrub typhus without eschar, I already told you, there are published reports saying only 20% of scrub typhus in India, you can actually find an eschar. And second thing is, unless you completely disrobe the patient and carefully look, you will miss an eschar. So that is something very, very important. But the other telltale signs of scrub typhus are very, very important, especially hepatic involvement, renal involvement, thrombocytopenia, as well as, transaminitis, whereas liver enzymes are elevated, and the typical facial edema. This is very important to recognize because it's an eminently treatable disease. And even before the results come, if the sample is collected, giving empiric doxycycline or azithromycin saves patients. We have seen patients get up from a comatose state and walk home in 72 to 96 hours. So I think that's a very important point to remember. And this was a paper published from Uttar Pradesh, which we try to differentiate between dengue encephalopathy or encephalitis versus scrub typhus. And they found 4 different clinical markers and lab markers. Mainly pneumonia was present in people with scrub typhus, elevated total leukocyte count of greater than 10,000 per cubic millimeter, absence of myalgia, which is very typical of dengue, and as well as petechiae were absent. Now, these were the distinguishing features between scrub typhus and dengue. And we are seeing more and more dengue encephalitis or encephalopathy quite often. Autoimmune encephalitis is a very, very important entity, and the workup for autoimmune encephalitis should be reserved after you have quickly finished testing for infective pathogens. It's a very expensive at this point of time. It costs anywhere between 12 to 15,000 rupees to run the 4 or 5 autoimmune markers that are shown on the slide. That is an enhanced experience. In about 3 years, they saw more than, now I think they've crossed more than 2,000 autoencephalitis cases. And nearly 12% of AES at NIMHANS today is autoimmune encephalitis. And these are encephalitis due to the immune response against some of the receptors, the central nervous system neuronal receptors, like NMDA receptor, the GABA, and the GAD receptors. They are very clear telltale signs to identify autoimmune encephalitis. Usually, a lot of behavioral abnormalities will be there in these patients. They're quite often young. They'll have an antecedent event of a febrile illness. They can present with movement disorders and a lot of autonomic disturbances. And they can also have refractory seizures. So these are but this is very important to remember, especially in tertiary care hospitals. When patients come to us, question to ask is it an autoimmune encephalitis? Toxin-mediated encephalitis, we have excellent investigations in this country of the Saharanpur encephalitis, which was due to ingestion of a pod that resembles tur dal. Children on the roadside, this is a weed that grows, they eat that and they get hepatic encephalopathy because a hepatotoxin. And of course, the Muzaffarpur, so-called within quotes, lychee encephalitis, which you're all aware of. I had the privilege of investigating this outbreak in Muzaffarpur. This is again a toxin-mediated hypoglycemia, very rapid onset in children, very dramatic illness. They're playing, evening they go to bed, midnight they have altered sensorium, and some of them are dead by morning 6 o'clock because they have very, very low glucose, less than 50 milligrams in their serum. So moving on to the second dilemma, the epidemiological dilemma. The question one has to ask in the lab, I'm reminded of my professor, Professor L.R. Dasgupta, who taught me clinical microbiology. He used to sit with requisition forms from 9 to 1 o'clock. He will finish diagnosing etiological agent based on what is in the requisition form. So remember, that is clinical virology. You will have to ask questions. What could this be? There is some information missing. You should definitely make attempt to get that information. The laboratory tests are only an aid. A lot can be done before, at least in acute encephalitis syndrome, I can vouch for it. So I think asking whether it's seasonal or sporadic gives you a clue to etiology. Whether patient is from an area where there is an outbreak, whether patient is from an area where a vaccination campaign recently concluded, especially for JE, because IgM antibodies will be positive. Whether there is an exotic infection. In Kerala, if you are a infectious disease physician or neurologist, you should your priorities are different. It's always Nipah, primary amoebic encephalitis. You know, because they're very exotic infections, and exotic infections will give you certain other clues as well. Healthcare professionals who are handling these patients will get infected, especially in Nipah or CCHF. So I think those are clues to look for. Whether it's occurring in a cluster or whether it's an isolated patient that you're dealing with. This is for people of my generation. AES used to be equal to JE. Now we know that it's no longer JE, but remember, it's still a very important pathogen to consider, especially if you go to northeastern part of India, in Assam and other places, because vaccination is still lacking in those places. And we also have not understood the adult onset encephalitis, whether the immunity given is lasting only up to 14, 15, and people become susceptible later. These are questions one need to ask. On the right, you see a graph which was the data from three important states in India, Uttar Pradesh, West Bengal, and Assam, from 2008 to 2015, while the number of AES cases being reported steadily increased. The blue line, the green line actually showed that it was not due to JE. JE, because of immunization following 2005, had come down. There was a huge gap, and this is what we addressed in a huge CDC-funded project for 5 years, and did surveillance in these three states of around 15,000 patients, and that gave us a lot of learnings, saying AES is no longer only JE. The other things that we did find, of course, we didn't find cerebral malaria, leptospirosis, sepsis-associated encephalopathy is very common, especially in tertiary care hospitals. Dengue and chikungunya can present as acute encephalitis syndrome, but they have certain distinctive features. If we are very careful in your history taking examination, you can certainly pick up clues on dengue, and also ordering the appropriate tests for them becomes very important. Unless you suspect, you will not look for these pathogens. HSV is the most important pathogen because it's eminently treatable. It's a crime to not treat HSV when it's suspected. Because if you don't give acyclovir, the patient will die 50% of the times. and in the remaining 50, they'll be maimed with some sequelae. So if you suspect encephalitis, be bold enough to start acyclovir and wait for confirmation after your sample is collected. Already told you the exotic pathogens as well as rabies are high consequence pathogens for AES. You'll usually have history of animal contact, especially dog bite in rabies, as well as bat exposure in Nipah. And as I said, CCHF and Nipah, you will see healthcare worker clusters. The third dilemma is diagnostic testing dilemma. Remember, in AES, testing is not a shopping list. You don't have to shop everything that is available. You have to be extremely smart and strategic. Now, Rahul, who is going to speak, not an AES today, is leading the ICMR AES surveillance in VRDLs. They have very rich experience. Before it was started, all of us sat together and battled for a long time and finally agreed on a very complicated, elaborate algorithm. But it's very important to use algorithms. Otherwise, you can get lost. There are more than 40, 50 pathogens in Indian context that can cause AES. Which one will you test? Which will be first? Which sample do you collect? And which order you test? All these are very, very important. But the most important among all these, I think, is your discipline in specimen collection and processing, because that's where you miss the diagnosis most often. Now, this is a algorithm that we adopted in the surveillance I mentioned to you, published in Lancet Global Health. You can have a look at it, published in 2020, 15,000 patients, where we suggested the first level diagnostic testing based on serum for JE, CRUB, and dengue in district hospitals in rural India, and then quickly sending the samples to higher centers and getting the results within 72 hours. Professor Amita Jain was our partner in Uttar Pradesh, and so you can have a look at that paper with a lot of details. The ancillary testing is very important, and information from it is very important, as I said, to distinguish between encephalopathy versus encephalitis, like total blood count, CSF cell count, and hepatic and renal parameters. Expanded testing is to nowadays what we recommend is that you do simultaneously the first level and the second level testing, because the first 72 hours is very crucial in acute encephalitis syndrome. And also remember, the aim of laboratory testing is to identify treatable causes of encephalitis. Which are the treatable causes? Scrub typhus, leptospira, malaria, bacterial meningitis, acute bacterial meningitis, which can masquerade as AES. These are very, very important, and you have to give top priority to it because the patient's outcome is most important for you. NGS has a role, but it has to be reserved when all the other pathogens have been tested. Of course, I want to emphasize about the role of pre-analytical factors, especially CSF. CSF, as I told you, is not available in most of the patients, and only serum is available, so you will have to be very careful. Lastly, the interpretation dilemmas. What happens when you cannot make out on a lab test? For example, you have a PCR negative, but all other parameters are suggesting that is herpes encephalitis. Or you have a serum JE IgM positive. CSF is not. Do you give enough weightage? What do you do with it? And when you have multiple positives. The JE trap, here is an 8-year-old from a JE endemic area, Assam actually. Fever and seizures, serum IgM positive, CSF not available, dengue outbreak is going on. Remember, arbovirus is a cross-reactive. So you have to do a test to distinguish between JE and dengue. And IgM in CSF is diagnostic. If it is only in serum, you have to take all other evidences before you give a report. A second case, a treatable sporadic case, 35-year-old with fever, confusion, focal seizures is the clue, behavioral change is a clue. This is AES due to herpes. And this is my favorite case because I got blasted by a clinician, my colleague, Dr. Tina, and me. A patient who was who had history of fever, seizure, and altered sensorium, was treated for malaria 1 month back. The following investigations were positive. Positive for Plasmodium falciparum and Vivax, mixed malaria. Smear was positive. Wheel Felix was 1 in 640. Thrombocytopenia present. Serum dengue IgM positive. Chikungunya positive. Scrub typhus IgM positive. Dengue NS1 positive. Professor Basavaraj blasted me and said, "You claim to be a national level lab. Everything in your lab is positive." So we pleaded with him and said, "Please give doxycycline. That's the only one you can treat." Patient walked back home. So multiple infections are a reality. I'm not saying that they are very common, but they are neither uncommon. In the 15,000 patients that we did surveillance in Uttar Pradesh, West Bengal, and Assam, 16% of patients who are positive had multiple tests positive. We never classified them as etiology, but they were 16% of them were positive. So you'll have to remember that never stop when you get one test positive. Interpretation is very, very key. Do not report in a hurry. Consider all factors before you report. To end my talk, here is the final take-home message. AES diagnosis becomes safer when every case is passed through these 4 lenses. Is there encephalitis, or is it encephalopathy, or is it an autoimmune encephalitis? Ask that question whenever you see a patient. Geography, outbreaks, exposure to animal bites, all these are very important when you consider epidemiology and what is going on in that area. Testing, as I said, is not a shopping list. Be wise, test the priority pathogens, give priority to treatable conditions quickly, and try to do not in a sequential manner, because by the time you come to the last one, the clinician has lost interest, or the patient is dead, or the patient is discharged. The idea is to get to diagnosis as fast as possible. Ask the question before you release the report, does this result prove that it is because of a pathogen? So the basic principles of AES management is stabilize the patient, correct the right sample, stratify your diagnostic testing, interpret properly, and report. AES is a syndrome, not an etiology. The diagnosis is built by combining clinical phenotype, epidemiology, sample timing, and the laboratory method. Thank you very much.
Thank you, sir. This is a masterpiece. Your talk is very crispy. Take-home message is very crispy, handy. And I think this is not a lecture. We should consider it as a oration. And usually orations do not follow with questions. So I think so. This is the best thing. I think it will be because the time is getting short and we are going to have this inauguration. The chief guest is waiting. Just I'm taking that leverage of just making these discussions during tea time and tea time, and we are getting the whole day. Now, before closing it, Dr. Amita Jain is available. Let us have her comments. Dr. Amita Jain,
So,
please.
thank you, Dr. Ratho. Thank you for very, very
We are missing physically here.
kind. Yeah, I know. I wish I could, but you know how Chandigarh is located. So, Dr. Ravi, it was a pleasure. It is a pleasure. It will always remain a pleasure to listen to you. Definitely, it's a oration. It's not a lecture or anything. So, I'm very pleased that I could hear it, and thank you for referring to a lot of work we did together. Each day we had a discussion or any project we did together was a huge learning experience for me. You very well brought out that AES, we do not have any straight answers. So we have to get the right sample, relevant clinical and epidemiological data, which is very, very important. Algorithmic testing, because you rightly said we cannot test for 50 pathogens in one go. And then following all the details, a detailed discussion before we come to a conclusion of what the etiology is. So it's truly a syndrome which need to be investigated with care. A right step in timely right step can save a life, and definitely we have to look at the sequelae which can be very, very damaging for the patient, so we can save that too. Thank you, sir, for very kind words. Dr. Ratho has already put a bar on questioning, so we don't have any questions. Actually, it was so complete in itself. And Dr. Ratho, thank you for the opportunity to say a few words.
Thank
I'm
you,
really
ma'am. Thank you
honored.
very much.
I'm really
It is,
honored to be.
yeah. We'll be waiting for you a day.
Yeah, yeah.
Thank you
I
very much.
wish I could. Yeah, thank you.
Thank you very much, Ravi sir, for that exceptionally informative and thought-provoking presentation. May I now request our respected chairpersons to kindly felicitate the speaker. May I now request our esteemed chairpersons and Gadkari sir to take their seat in the audience while we get ready for the inaugural session. Thank you very much, Dr. Amita Jain, for your precious time and for your valuable inputs. Can we have a big round of applause for our speakers and the chairpersons? Now, as we move forward towards the inaugural session, may I request Dr. Ishani Bora, Additional Professor, Department of Virology, PGIMAR, to please come over and take over the proceedings.
A very good morning. On behalf of the VIROQuest 2026, I would be happy if you can just bear with us. We are waiting for our chief guest for us. Thank you. A very good morning. On behalf of the organizing committee, it's my privilege and pleasure to welcome you all to the inaugural ceremony of the National CME VIROQuest 2026 with the theme Decode, Diagnose, Defeat, dedicated to the advancing knowledge and fostering collaboration and promoting excellence in the field of virology and infectious disease. Today, we are honored by the presence of eminent personalities whose contributions to medical education, research, and healthcare continue to inspire us. May I now request our organizing chairperson, Professor Mini P. Singh, to kindly accompany our chief guest, Professor Vivek Lal, Director, PGI Chandigarh, to the dais. Thank you, sir. May I now invite our organizing secretary, Dr. Kapil Goel, to accompany our guest of honor, Professor R.K. Ratho, Dean Academics, Head Department of Virology, PGI Chandigarh, to the dais. Thank you, sir. Thank you, ma'am. We would now like to welcome our distinguished dignitaries with a bouquet. Thank you, sir. To evoke the wisdom, knowledge, blessings of today's academic event, let's seek the blessings of the Almighty and Saraswati Vandana. May I now request our dignitaries to kindly come forward for the lighting of the ceremonial lamp. I would also invite our Senior Virologist Dr. Deepak Gadkari, ex-director, NIV Pune, and also Dr. V. Ravi, ex-head neurovirology NIMHANS, to join on stage for the ceremonial lamp lighting. Sir. Thank you, sir. Thank you so much. To formally welcome all the participants and set the tone of today's academic deliberations, I would now like to invite our organizing chairperson of VIROQuest 2026, Professor Mini P. Singh, to deliver her welcome address. Ma'am.
A very good morning to all of you. On behalf of the Department of Virology, PGI Chandigarh, it is my proud privilege to welcome each one of you to VIROQuest 2026. We are gathered here today to conduct this national CME, an initiative that brings together some of the finest minds in medical virology and microbiology from all across the country. I extend my welcome to our distinguished dignitaries on the dais, our chief guest of today's function, respected Director Sir, Professor Ate Ratho, Dean Academics and Head Department of Virology, and my colleague, Dr. Tapil Royal, the organizing secretary for this CME. A heartfelt welcome to our dignitaries of the dais, Professor Sanjeev Handa, our Sub-Dean Academics, Professor Ashok Kumar, our medical superintendent, our senior faculty, Professor Deepak Gadkari, Professor V. Ravi, Professor Anita Desai, other guest faculty, former faculty of the Department of Virology, Dr. Bejanti and Dr. Binod, who have joined us for this important event, and also the esteemed faculty members of our institute. No program can be complete without the active participation of delegates who have come to attend this program from different parts of the country. The theme of this CME is Decode, Diagnose, Defeat. This triad represents the third cycle of our response to emerging viral threats, be it Ebola, Nipah, or hantavirus. To decode means to unmask the pathogen, unraveling its genetic sequences. To diagnose requires deploying advanced laboratory tools for accurate and swift detection. And finally, to defeat signifies translating the lab data into decisive clinical management, development of vaccines, and also antivirals to combat the pathogen. Over the course of the day, our scientific program will delve into critical public health priorities, which will be aligned with this theme. This occasion deserves the guidance of leadership that exemplifies administrative and academic excellence. It is now my distinct honor to introduce our chief guest for today's function, the Honorable Director of our institute. As the head of our premier institute, Sir has been a driving force behind medical education, research innovation, and also healthcare infrastructure development. Under his visionary stewardship, PGI continues to achieve new benchmarks in clinical excellence, postgraduate training, and research, both nationally and also globally. We are very grateful to you, sir, for sparing time out of your demanding schedule to grace this occasion. We are equally privileged to welcome our guest of honor for today's inaugural function, Professor R.K. Ratho, Dean Academics, and also the head of our department. Sir has been instrumental in transitioning our virology lab infrastructure into a state-of-art reference center and establishing national networks that bridge basic science with public health policy. Thank you, sir, for your presence, your leadership, and your continued encouragement towards our scientific endeavors. Last but not the least, I shall be failing in my duty if I don't express my appreciation to the faculty and other members of the organizing committee of the Department of Virology, as their active participation is what drives the success of this academic forum. I trust that the deliberations today will prove intellectually stimulating and scientifically rewarding for everyone involved. Thank you very much and welcome to the CME.
Thank you, ma'am, for your warm welcome address and for your leadership in bringing together this excellent scientific forum. It's now my privilege to invite our esteemed chief guest, Professor Vivek Lal, Director PGI Chandigarh, to address the gathering. Sir, we would be honored to hear your thoughts on this event.
So, Professor Ratho, Mini P. Singh Kapil, distinguished faculty from Bangalore and from the Oxford of the East, that is Pune, and other distinguished members in this hall. I'm actually, I am apologetic because I couldn't attend this lecture, acute encephalitic syndrome. I had all plans to attend it, but then the seat I am, my time is not my time. Someone's supposed to come at 9:30, and so the person turned up. And that's the reason I got a little delayed. Hollywood's #1 cinematographer, the fellow who does all the stunts for Tom Cruise and all, is actually admitted in PGI. So he had undergone an emergency cervical surgery. He was paragliding in Peer Billing, where he met with a crash, and he was airlifted to PGI Chandigarh. And PGI is, amongst the best centers for cervical spine injury in the whole world. And they've done a fantastic job. So it was concerning that suddenly PGI has now got a name in Hollywood also, all the places. So I am actually delighted to be here. We just heard what Mini has just said, and we just heard what Mahanta virus did on that cruise ship. We know what COVID did to the world, and one doesn't know how many more viral outbreaks we are likely to encounter. And the only way to treat a virus is stay vigilant against it. If you look at how that hantavirus entered that cruise ship, it's a very interesting story. There was a couple which went nature walking, and there they came in contact with rodents. The rodents infected the virus, infected them, and then they went into that cruise ship, and the rest, of course, we all know the mayhem that took place on that cruise ship. So in a way, otherwise the cruise ship would have been, sued for God knows how many dollars. But it was proven that they got infected when they were doing nature trekking before they kind of embarked on that cruise. I can tell you, of all the branches in neurovirology, amongst the most devastating happens to be what viruses do to the spinal cord and to the brain as a post-infectious complication. Amongst the most devastating, we have a treatment for stroke today. We have a treatment for gliomas. But I'm telling you, when viruses go berserk, we have no treatment. We have no treatment for a virus which has gone berserk. If you look at the mortality today in neurology, you take it from me, almost every second patient in the ICU, in the neuro ICU, will be related to a viral attack, either immediate or in the past. So acute post-infectious demyelination is mayhem. It's mayhem. You give steroids, you give IVIG, you're left with complications. You are left with complications. There is never 100% recovery in these. Post-measles encephalitis, SSP, uniformly fatal. There's so many others that sadly bring home the mortality, the morbidity, and above all, the relevance of virology in today's world. I do not know whether you're aware or not, the present director of National Institute of Health happens to be Avinder Nath. He's a PGI product. He takes care of the communicable diseases and virology section. So I met him at a World Congress, and we were just discussing over a cup of coffee. In his opinion, I asked him, what do you think is the most devastating, bug? And he didn't bat an eyelid, and he said, it's the viruses. It's not bacteria. It's not tuberculosis. It's viruses. Because a virus strikes at will. And that's when the COVID pandemic had not taken place. A virus strikes at will and does what it wants to, and often escapes scot-free. Long ago, I think it was Gene Linderman who got the Nobel Prize for the discovery of interferons. Yes, it was Linderman. I read his book, Interferons, when I was doing my MBBS. He wrote a book on interferons, I read. And that came with a lot of promise. But if you look at the treatment of viruses, that's one big blind spot. It's a big blind spot in the treatment armamentarium of medicine. You do have herpes simplex, which responds to acyclovir well. Not always. It's fraught with complications. We all know that. And even if a patient does respond, all it means is he makes it, but is left with temporal lobe damage. Looking at the carnage which herpes simplex encephalitis does. There are so many other viruses which actually don't have a cure. And I quote what Winston Churchill said: we were naked in front of the enemy when they were fighting the Nazis in the Second World War. I think when it comes to medicine, we are actually, compared to the other branches, we are naked in front of viruses. We still don't have the kind of impactful and transformative drugs that we have for other bugs. And that is where we need to kind of rev up our, research. We need to rev up our thoughts and our action. And I think this VIROQuest, besides, of course, debating so many issues regarding viruses, it's important. I'm sure it will also make you aware of just how devastating a viral infection can be. We simply talk of the microbiology part of virology. I do not know whether you know or not, the severe asthenia that often accompanies a simple viral infection can make a most powerful wrestler on this earth cry. It's a phrase that a simple viral infection causes such severe asthenia that it can make a most powerful wrestler on this earth cry because of asthenia. And that is how debilitating, how damaging a simple viral infection can be. Forget the rest of what it is capable of. So I think with these words, I welcome you all. I am happy that you're finally having a VIROQuest. It's been long overdue, and I request you to have it once every 2 years, Minnie. It's important that you have this once every 2 years because things are changing so fast. Viruses are changing so fast. New viruses are coming in, and the old ones are assuming more monstrous forms. I don't seen them dying, except for smallpox long time ago when that Bangladeshi lady was the last case reported on Earth. I have actually don't see any respite from these viruses. Measles vaccination has significantly reduced the incidence of post-measles complications. But then the sad thing is, instead of cursing the virus, people are cursing the vaccination on ground zero. On ground zero, and I won't name, you all know who that person is who's gone after measles vaccination, and he's got his own stooge there trying to, do this and that at NIH. But that's across the 7 seas. I'm not concerned what they are doing. I'm just telling you, in India also, instead of trying to understand that it's the virus which is knocking down the patient, they are going after the vaccination. And that is something that you need to kind of drive home, that if you have to really become measles free, you will have to vaccinate. Vaccinate with a 4x4 aggressive wheel drive mentality. Without that, you're not getting hold of these viruses. These viruses are too smart, and at every step, they are one step ahead. At every step, they are one step ahead. That's the point I'm trying to make. I hope you've understood what I've said. And I hope if we have some community medicine, healthcare workers here to emphasize this aspect amongst the common man, we should hold simple public gatherings. I'm not saying CMEs, I'm saying public gatherings. Public gatherings have a more dividend paying potential than CMEs. This is a locked room, LT1, a very hallowed room. But if you have a public gathering, in India at least, I can tell you a public gathering makes a lot of difference. One person will listen, he won't keep quiet. He's going to gossip around 10 places and say, look, someone told me it's not the virus. It's the virus which is damaging. We should go ahead and get our children vaccinated. Because this vaccine hesitancy is the new norm. I don't know. I don't know. A crazy society makes you do crazy things. And we are living in a crazy society. So vax hesitancy, this new word, protein maxing, vax hesitancy, these are the new norms. I don't know why people are going nuts, but they are. So if we have to prevent a resurgence of viruses, the only way forward is be vigilant against them and use whatever we have in our armamentarium, thanks to the wisdom of our past masters, to ensure that that armamentarium, that vaccine drive does not in any way dwindle with time. Thank you so much. I wish this audience all the best for today. It's a one-day CME. Ideally, it should have been a 2-day CME. You're doing it after 5 years? For 5 years. So if you're having a one-day CME after 5 years, that's not good virology. Good virology would have been 2-day CMEs every 2 years, because that is what viruses are capable of doing. But nevertheless, well begun is half done. Continue this good work. You have the support of the society. You have the support of the PG administration. And I hope that you all go back wiser and more learned and are more prepared to take on the cudgels against viruses. Namaskar.
Thank you, sir, for your encouraging words and your sharing your vast experience and visionary perspective with us. Thank you, sir. It's now my privilege to invite our distinguished guest of honor, Professor R.K. Ratho, Dean Academics and Head Department of Virology, PGI Chandigarh, to share his valuable thoughts with us.
Good morning. Our director, Professor Vivek Lal, Dr. Minni, Dr. Kapil, Dr. Gadkari, Dr. Ravi, and all the invited speakers, well-wishers, all faculty, head of the departments, delegates, and colleagues. I don't have any words. One thing is that I am, at this moment, is a nostalgic moment for me. But we had our director. He's a clinician, no doubt. He's a researcher, no doubt. He's a virologist, purely virologist. If you read one of his chapters on rabies, it gives much more detail of a virology, whatever possibly you have not known. And that book, it happened to us to see. So it's such a beautiful person. And today he proved that he is also an epidemiologist. So every component is studied in him. We are that's why proud that he gives every football. So thank you, sir, because you are here and we are waiting for this moment. And mostly I don't have nothing more to say. Everything has been told by him. I wish that this will be a great success, and I congratulate Dr. Mini because she has taken single-handedly with the department, of course, support all these steps, doing the CME, inviting such a beautiful people, experts of their area, and it will be definitely very, very useful, and it will be a momentum to remember. And as director said, the momentum has to go every 2 years for 2 days CME. It is very worth of having, and with the support of the administration, nothing more is required. That's very important. And I have also seen Dr. Pujari coming from USA is giving a surprise at this moment without anybody knowing that he is coming to here. He is my second PhD student. So it is congratulations and welcome to this. So many more like this nostalgic moment. Everybody, I'm seeing them, I'm getting emotional. So I think that this would be a great success, and thank you very much. Congratulations, Dr. Mini, for the team.
Thank you, sir, for your encouragement. Your contributions in the field of virology will continue to motivate the future generations. Now, as a token of appreciation and gratitude, may I now request Professor R.K. Ratho to kindly felicitate our chief guest. May I have a round of applause for I would now request our chief guest, Professor Vivek Lal, to kindly felicitate our guest of honor, Professor R.K. Ratho. Thank you, sir. As we come to the conclusion of the inaugural session, it's my pleasure to invite Dr. Kapil Goel, Organizing Secretary, VIROQuest 2026, to propose the vote of thanks.
Thanks, Dr. Ishani, for inviting me to deliver the vote of thanks. A very good morning to all of you. It is my privilege and honor to deliver the vote of thanks on the behalf of Organizing Committee of VIROQuest 2026 and the Department of Virology. At the outset, I extend my heartfelt gratitude to our respected Director, sir, for graciously consenting to be the chief guest for today's CME. Sir, our department is extremely thankful to you for sparing your valuable time to be with us today. Under your able leadership and guidance, our department remains committed to provide the highest standards of viral diagnostic services for patient care while continuing to excel in academic and research activities too. I can confidently assure all the delegates that today's CME will be a powerhouse of knowledge and a truly enriching academic experience. I would also like to express our sincere gratitude to the PGI administration for their continuous support. Our special thanks goes to the Department of Telemedicine for providing the online platform, and Dr. Uma Nahar for her valuable inputs for stage management. I would like to extend my heartfelt thanks to the Punjab Medical Council for granting CME credit hours for today's program. We extend our heartfelt thanks to all our eminent speakers, chairpersons for sparing their valuable time and sharing their expertise with us. My sincere thanks goes to all the former and present senior faculty members and colleagues who have taken time for this CME. I would like to acknowledge the dedicated team behind the successful organization of this CME. The Department of Virology has worked tirelessly day and night to make this event possible. No such event of this scale can be successful without the support of sponsors, so we are extremely thankful to them. We are celebrating decades of contribution of Dr. Rathos through this CME today. So before I conclude, I would like to share a small anecdote, especially what Mrs. Ratho madam told me. Madam said that Kapil, हमारे घर में तो कभी शाम होती ही नहीं है. So I asked her why she felt so. She smiled and replied, "Sir is always at PGI, and we hardly had evening tea together." At that moment, I realized how true those words were. Whenever we looked for sir in the evenings, he was always there in the department. अंत में मैं दो पंक्तियां कहना चाहूंगा और अगर आपको अच्छी लगे तो तालियां जरूर बजाइएगा. पहले सर की हर शाम थी पीजीआई के नाम, पहले सर की हर शाम थी पीजीआई के नाम, रथो मैडम के लिए है, मैडम अब हर शाम होगी आपके नाम. थैंक यू सो मच. जय हिंद.
Welcome back, ladies and gentlemen. I hope with all that caffeine inside, you're totally refreshed and energized for the sessions ahead. As we begin the plenary session celebrating Professor Ratho's extraordinary contribution to the field of virology, it is my privilege to invite Professor Mini P. Singh, who has shared the longest professional association with Sir and has witnessed his remarkable journey at close quarters, to come on stage and kindly share her reflections. Now.
Thank you, Dr. Pooja. It is my profound pleasure and privilege to welcome you all to this plenary lecture today. Our speaker this morning is a stalwart in the field of medical virology, a mentor and an eminent scientist who truly needs no introduction to this august gathering, Professor R.K. Ratho. To say that the Department of Virology and Professor Ratho are synonymous would be an understatement. His illustrious journey with the department spans over 34 years, beginning from his appointment as an assistant professor in this department. As a proud alumni of this premier institute, Sir has nurtured it in return, serving as one of the longest tenured head of the department for nearly 26 years. This CME is specially dedicated to Sir as a tribute to his remarkable journey, his visionary leadership, and his lasting legacy in shaping the Department of Virology. Sir's contributions have not been limited to built-in services and systems. He has also strengthened the very scientific foundation of medical virology. His early work in classical virology, including the animal inoculation models, the serological assays, has trained generations of students, many of whom are here, to understand the viruses much beyond the test report and to respect the biology behind every diagnostic result. His academic and research interest has spanned important viral infections of public health significance, including dengue, Japanese encephalitis, and he has also contributed immensely to understanding the respiratory viral infections, especially the pathogenesis of respiratory syncytial virus. Ladies and gentlemen, this breadth from arbovirology to respiratory virology reflects his rare ability to connect laboratory science with clinical disease, outbreak response, and national public health priorities. On a personal note, my journey has been intertwined with his leadership. Ever since I joined this department as a junior resident in the year 2000, Sir has been at the helm, I fondly recall those early days. Many of you whom must be knowing the era of the Paul Bunner test, the meticulous guinea pig powder preparations. I know how I hated to till those loving guinea pigs and the heme agglutination inhibition test. I must admit, we were actually a little apprehensive of Sir's deep dive discussions, especially on the ELISA technique. Sessions that were actually intellectually rigorous, exhaustive, and unforgettable. Dr. Vajanti, you will agree with me that Sir's sessions would last for hours on a Saturday afternoon, just as we were all looking forward to our half-day weekend. So these actually remain the foundational memories of our training. Under Sir's able guidance and mentorship, the department has grown substantially, and today we can boast of an advanced cell laboratory, the APETS referral lab for dengue, JE, chikungunya, and under NVDCP, the ILI centers, and many more. During the COVID-19 pandemic, our department spearheaded North India's test and response as an ICMR center of excellence, helping establish more than 150 laboratories across different states and union territories and training more than 300 personnel. We also served as the reagent depot, a kit validation center, a clinical trial support unit, a PETS quality control lab, and at the same time engaged in capacity building trainings in advanced diagnostics and lab quality management system. Capacity building has been a core mandate of our department, with regular trainings being imparted to the microbiologists and the technical staff from various medical colleges and hospitals all across the country. The academic legacy of this department is global. Our MD and PhD alumni occupy prestigious positions both within the country and internationally. And I'm actually overwhelmed to see Dr. Sujit Pujari, who has come all the way from United States to be with us today. It is interesting to note that out of us 7 current faculty members, 3 of us have been Sir students, myself, Dr. Tapil, who was also his thesis student, and Dr. Shubhabrata Sartar, who was his PhD student. Not only in academics, the department has a prolific research output with numerous articles in reputed international and national journals and various ongoing international and national projects. At this milestone moment, I also want to thank Madam Ratho, who has been always by Sir's side, and as the timeless adage goes, behind every successful man, there is a strong woman. Kapil has already told कि सत्य धर्म में शाम नहीं होती, and Madam has been the steadfast anchor in Sir's life throughout these decades of relentless dedication. We all know that academic and scientific excellence, it needs a lot of personal sacrifice, and I'm sure Mrs. Ravi knows it very well, and I thank Madam for her enduring patience. And on a personal note, ma'am is an excellent cook, and no one will leave Sir's house without a sumptuous meal and tasting for something new. That's my personal experience. So this CME is specially dedicated to Sir as a tribute to his remarkable journey and his visionary leadership in shaping our department. Just as parents entrust the values to their children, so too must the children step forward with independence, carrying fresh ideas to explore the world and elevate it to new heights. Guided by Sir's legacy, each and every faculty member of virology is dedicated and ready to shoulder the new responsibilities as we step into a new era. With conviction and courage, we are confident that this department will not only reach new heights, but also set a shining example for generations to come. And I evoke blessings from all of us who have joined us today. Moving forward with our scientific agenda, it is now my distinct privilege to introduce the esteemed chairpersons for this plenary lecture. We are honored to have Professor Deepak Dattari, a veteran pioneer from APET's National Institute of Virology, Pune. Sir is a master mentor who has trained generations of India's leading virologists. His foundational work on arboviruses and early HIV surveillance has laid the absolute groundwork for modern molecular epidemiology in our country. So please join us. We are privileged to welcome Professor V. Ravi, fondly known as Virus Ravi, former head of neurology and dean of basic sciences at NIMHANS, Bangalore. Sir has spent 4 decades translating complex lab data into decisive, life-saving clinical interventions on the ground. Sir has worked on Japanese encephalitis to leading the pandemic response team during the COVID-19, has set an example for all the budding virologists. Also, it is my immense honor to welcome a legendary figure in medical virology, Professor Shobha Barur, former professor of the Department of Virology at AIIMS, New Delhi. Madam could not join us today in person because of her some personal commitments, but she has kindly joined us online. She has been a pivotal member of premier national task forces, and her expertly drafted protocols have shaped diagnostic policy across the nation. Now, may I request our esteemed chairpersons to introduce our plenary speaker for today, Professor Artya Rathod. Thank you, everyone.
Dr. Ratho, I think this is third important event of the day. Chronologically, inauguration was first. Second was Dr. Mini's birthday celebration, and the third is your lecture. Mini has introduced you already so much details because yeah, it was department thing, but she missed lot many awards and accolades. He received scholarships and foreign collaborations and an advisor. Few years back, I think he defected from science to administration. I think he excelled there also. That is also a good experience to have it. And this morning he became very nostalgic, 15 days before his retirement. And I was just telling him this day, today, 15 June is also a very important day in my life because I retired 26 years ago, same day. No, I'm not that old. I retired. Voluntarily retired a bit early, but anyway. So Dr. Ratho is going to talk about little bit neglected virus, respiratory syncytial virus. It's a renaissance to global perspective or global prominence, and it is very good because people know a lot about HIV and hepatitis and arboviruses, but RSV is a little lower grade virus, but still very important. I think we'll hear a lot from you, Dr. Ratho. Thank you.
Few words from my side. 3.5 decades of friendship, and we've traveled together for many meetings. He's a very dear friend. And very recently, he was the president of Indian Virology Society, and it was a very proud moment for all of us. The Virology Society has plant virologists, veterinary virologists, aquatic virologists. So Ratho was the president of Indian Virology Society. A very, very, great achievement. And of course, all the other things have been told by Mini elaborately. And from my side, Ratho, welcome to the good old bad boys virology club.
Waiting for that.
Yeah,
Desperately.
Can I say something?
Indian way of honoring.
This is Dr. Brood. Can I say something here? Can you hear me? Hello? Hello, Dr. Gadkari. I would like to say a few words here.
I think I will have it.
Yes,
sometime.
please. It has the blessings of Sringeri Shankaracharya.
Oh, yeah. Great. Good noon. A real moment which I think everybody would like to have in their lifetime. Only one desire I had, to come and to go smoothly. So possibly Dr. Minnie has made that things are very clear. So I feel I will have a smooth travel out from these responsibilities. Thanks, chairpersons, Professor Ravi, Professor Gadkari, and Professor Subhabrur, madam. I think we are listening, ma'am, to you and missing you by person here. I really felt that she should have been here. That would have been the most blessed moment in my life. So she loves me very much. We love her, and she loves much more than that. So that is possibly what I got in my life. People gave more love than what I expected. So that's why I feel always satisfied. That is what basically required. Just before going to the topic itself, since a moment where things have been told so much by Dr. Minnie, it is just reminding of how the things went on. So I came to this institute as a JR in July 28th of 1986. So that means I'm sort of just 28 days to cover 4 decades of life in one institution, not going away for a long time. I used to go to conferences, but I used to reach on the first day and I used to leave by the last day. No extra day I have taken till date. It happened with both national as well as international conferences. So I used to love the department. I used to love every part of the department, everybody, every corner. So God also gave me a chance to rebuild the department in different way, whatever we wanted to have it. And when you have your faculties, they are supportive to you, you are the most blessed one possibly. So I had that privilege. Whatever I used to do, my faculty used to support like left and right. They never used to say anything. So that was the good time I had for those 4 decades. When I started counting, it became something that is it so? Half of my life gone in one place. 1992 September, I joined as a faculty. So I was the last student of my teacher, Dr. S.R. Pal, Professor Satyaranjan Pal, who was friend of Dr. Kalyan Banerjee, sitting as a director of NIV Pune. And Dr. Kalyani Banerjee used to come as an examiner for me from there because they were good friends. They're the best possible virologist up that time. They used to have a lot of basic virology teachings and all. Dr. Pal used to have the same thing. Whatever he taught, something imbibed inside. So the way they used to, they were saying that it used to go for hours to have discussion with students. So we used to have coffee rooms where it used to span over 1 hour, 2 hours discussion because that used to make a teacher more comfortable. So I was the only faculty from 92 to 95. We had three faculty. Dr. S.R. Prasad, again my mentor. Still he's there in Davangir, I think. So Tamaka, Davangir. I used to love. He used to have good teacher, and he's a bird watcher, and he loves nature, and he will teach Sanskrit. So that is his quality. He makes you very happy. So we had a outbreak in it was in November, December. So maybe 90 or 90 I think, in Haryana. The first outbreak of JE investigated. So he used to say, Rath, अगर आपको आर्बोवायरसेस करना है तो आपको घर छोड़ना होगा। कैसे घर छोड़ेंगे? हिल से तुमको नहीं छोड़ना, तुम तो स्टूडेंट हो, मुझे छोड़ना है। मैं क्या करूँ सर? बोले एक चीज करना होगा, आप रात को 9 बजे हमारे घर आओगे, मैडम को बोलोगे कि हम दोनों रात भर जा रहे हैं काम करने। सो आप एविडेंस हो कि मैं रात को बाहर जा रहा हूँ। So you have to come back at again 5 or 6 o'clock, hand over me to her, and then you are allowed. So we worked 15 days continuously to work upon this outbreak, because in working with the dengue, arboviruses, you need cold temperature. Those days nothing was there. December was the month when the temperature outside was 4 degrees. So we used to work on the routinely on the table without much of ice and all things, and we used to work in a cold room, put things and centrifuge and do working. And that was proved as a first JE outbreak in 1990 in Haryana. Till that time, none of the North Indian countries, states, they were reported of this disease. So this way, I think Dr. Mahajan, after Dr. Pal, 92, I joined as assistant professor, and then Dr. Prasad, Dr. Indrani, and myself, 3 were there. By 95, everything was vacant. I was the only faculty. And Dr. Mahajan, R.C. Mahajan, used to be the office sitting head till 1998, then Dr. Nancy Mala for 2 years. Possibly there is a unique example would be, as an associate professor, I was given the head of the department in 2000. It was not an example anywhere. Then 2005, I became professor. Then I got Dr. Mini. 2006, you came? Yeah, as a faculty. So from 1 faculty to 2 faculty, Dr. Vajanti was there that time, yes. So she was there with me. And Dr. Mini came. Then Dr. Vajanti left in 2012, 13. So soon after she came, then we had a chance of having Apex Referral Laboratory for advanced diagnosis of dengue, JE, and chikungunya. That's the first center it was given to us by NVBDCP. Then the start of swine flu, H1N1. So we had the center for that in 2009 and 10. 2011, Dr. Gadkari's rule came. Sir, I wanted to tell that because otherwise people will not know that. So Dr. Gadkari was the mentor for all through India to establish VRDLs. That time it was grade 1, grade 2, grade 3. The concept it went through Dr. Gadkari and Dr. UC Chaturvedi. These two doyens, they used to travel all through.
Don't forget name Nivedita. She was the holding fort at the headquarters.
At the center. They started identifying centers in different places and then nominating them as a VRDL. And 2014, it was upgraded to regional VRDL. So that way, one more. And 2015 and 16, we got the WHO reference center for measles and rubella, which Dr. Mini started working on that, and she is still that is working. And then we had COVID, also what she said it. Now, besides that, we have few more centers like One Health Concept, BSL3, and few more activities are going on. So this way, the department started from 1 faculty, and as of now, we are 7 faculty with 1 tutor. 8 people are working. So the day once I started, it was 2 rooms left for virology. One was office and one was multi-purpose. Teaching, molecular, everything was going on in the same room. So from there, the present scenario is with all the facilities, what I said. And with the advent of this regional VRDL, with the mandate of BSL3, the BSL3 final validation is going to happen tomorrow, day after tomorrow. So it will be functional soon. That was the last commitment which I have to have before I leave this institute. So it will be possibly done, and then I think the department will be completely, almost, you can say, equipped with to deal with any sort of those outbreaks and things. So we used to read pandemic, outbreak. The first pandemic experience came in 2009 when H1N1 came. It was a tough time, no facility, no concept, everybody moving around, everything, what you have to do it. And Dr. Varsha, she was, I think, available, and they were giving all reagents from NCDC, NIV Pune. And gradually, the NIV Pune took over through the mentorship of Dr. Nivedita and the directors of DG ICMRs. So now it is a full-fledged ICMR with so much of facility, equipped with everything. They are able to do it. That is the greatest achievement of India in healthcare, that we can do whatever we can feel, including the vaccine what we had. So it is nice. And going back to the topic, I think from the beginning I should declare that Dr. Mini has made my things a little clear, saying that it's a plenary lecture. Plenary means plain. Whatever you will say, no up and down. Like previously they said, there is like all quest, all those 4 or 5 points you have to deal with that. So here nothing. It's a plain. So I think people will bear with me. I will have some experiences, whatever we had during this, working with some of the viral infections. Yes, Dr. Gadkari, what he said. Besides this, Dr. Ravi was my mentor and selector. He has come as an expert for my promotions. Almost all promotions he was there as an expert, virology expert. So that was the charm that you are with the boss here. And Dr. Gadkari, we have said a complete 1 month time in NIV Pune when I went as a INSA visiting scientist, and so much of love. And then I learned in 1997, 98 how to do virology and what sort of thing, vision of a virologist, many things. So they are like best people available, and they should be available for years together. So that is the praying to the God that they should be there and people should get the benefit out of them. Okay. So now I thought that this would be a very useful thing because of the changing scenario of respiratory infections. See, the day it was there, decades when people start working with the bacteria, and it was the time of bacteriology. Now it is just change in paradigm shift from bacteria to viruses. And since 2000, you can say through avian influenza, then SARS, then 2009 you have the H1N1, then 2020 the COVID, again the Ebola and Nipah all are moving around. Then maybe anything happen. So the pandemics are just looming like. We used to think what is pandemic, now we are within the pandemic. So that is the change, things what is happening. Yeah, so so I thought to look some of the viruses with these respiratory infections and more so with the acute lower respiratory infections. So you see that children less than 5 years of age, there would be about 10 million deaths worldwide if you see the global scenario. Then 1/5 they die due to low respiratory infections, and 1/4 of that is contributed by India. So the mortality rate in India, you imagine, such a high burden of that. If you look into the viruses, of course, you will have influenza and then respiratory syncytial virus, metapneumonia, and much more. See the global incidence. We were looking for the lower respiratory infection. 33 million RSV related lower respiratory infections worldwide. If you take into that, you see 1/10 or 11th of that, they require hospitalization. Now, of those hospitalized, if you go into the data, see 80% of them, they will be previously normal. A normal child going to respiratory infection to lower respiratory, to morbidity and mortality, you imagine, is really shocking. So 80% are their normal people. That means rest, you see, there will be and the age group you see less than 6 months of age, 1 to 6 months. Infants are more prone for this type of infections. And you say infants, those who are preterm, they will have 3 times more chance to acquire this infection than the other ones. And mortality wise, if you see it, around 15 to 20%, the mortality due to acute lower respiratory infections, less than 5 years, they are due to RSV. So RSV contributes so much of disease burden as well as mortality. And you look into the risk factors, even in high income countries, you have more than 70% children that die due to comorbidities. And do a odds ratio, you will find sepsis and pneumothorax would be one of the major contributors for the mortality. This table shows you that RSV contributes 50 to 80% RSV infections. Now rest, they follow it. While searching, very recently I could get this. I was thinking why people are not working on that. Why it has been getting last like 2010 onwards, 10 onwards, the things are getting. So this paper I could get, this is 1971, published by PGI, Dr. Agarwal, S.C. Agarwal. Dr. Ravi must be knowing the name, just I know the name only. And then Dr. Mahajan and Dr. Ganguly, they said 20% of the children, they used to have RSV antibodies. So RSV that time it was circulating, it was there. That means the majority of work with RSV, so far I knew, was through Dr. Subha Brur and Dr. Sulinder, USA. They have a collaboration. They were working for a quite long time. So this work relates to 2003, when they could say that of 200 nasopharyngeal aspirates, RSV isolated in 34, and others, around 45 samples, they could identify RSV through molecular also. That means 45 out of 200 is something around less than 25%, 20 to 25%. That percentage with RSV, it remains almost constant. Wherever you study it, around 20% cases you will get RSV. One of the studies where I think we have Dr. Suresh, the clinical pediatrician, and Dr. Subhabrat is our faculty, and the study was in our department, where again it says that RSV, you can say 51%. This study has a little higher, maybe this case selection was very, very strict because the clinician was involved. They might have selected those very suspected cases. That's why the positive was 51%. So otherwise, usually you will get 20 to 40% positivity, whatever study you see, even North India and South India, wherever it is. So while working it, Dr. Subhabrat, he said, can we analyze, because the work was going on previously before the COVID. So he said, okay, let us put in bar like pre-COVID and during COVID. During pre-COVID means October 19 to February 20. Then during pandemic period, the Delta wave and Omicron wave. So July to December 21 and January to July 22. This is the Delta and Omicron. You see the RSV. The positivity was 51%. Now during Delta it came to 10%, and then Omicron it came to 0.9%. A drastic, you can say, fall of this only one virus. No other viruses, they were affected with that. Month-wise, you see, October, November, December, the winter months, usually the RSV. And once the COVID came, gradually it came down. None of the other viruses, we had not much of high isolations, but still they continued to have in the same way. So somehow RSV got affected because of its scenario, position, or pathology, the virus itself. But it was only the RSV had got such a drastic reduction of its positivity. 0.09% means it is negligible. That's why. Interestingly, people thought, what is happening with RSV? So the usual thing is that with the acute lower respiratory infection, RSV once starts, you will have severe neutrophilia, high count of neutrophils. Once the neutrophils are engaged with that, they are going to produce like the elastase. Now the elastase that disrupts the matrix structure of the epithelium. Once the matrix is destroyed, you know the disease pathology starts thereby. So that aggravates the scenario. So this is how people they postulated. Acute lower respiratory infection, there will be high viral load. Whatever the viral load is, definitely it is more than the recovery stage. Once the viral load is more, then you have more of neutrophil infiltration. Neutrophil infiltration, then it is going to have damage, the morbidity increase over the time, because the RSV, okay, you say 3 to 7 days incubation. So by the weekend, the person is going to recover usually. So recovery means it is the CD8 T cells, not CD4 and other cells. CD8 T cells are the much more important for its protective role. So that is what people have seen it. And then if anybody has to have a target, they say the potential therapeutic target you can put as anti-neutrophil therapy, or you can suppress the dendritic cells, or you can have TNF alpha means anti-TNF therapy, or lastly vaccination, because you need to have CD8 response and good response. Vaccination would be the best way to take care of. So you have bronchiolitis, you have viral pneumonia, different type of the clinical presentations one can have. And if you see the preterm less than 35 years gestation or infants younger than 6 months, what you have seen, they are much more predisposed to this RSV than the other thing. This possibly stimulated a thought. Dr. Bajanti is sitting here. She had a ICMR project before she left PGI, and she had Dr. Subhabrata as a scientist to that. And then once she left, then it's Dr. Subhabrata, she joined as a PhD and continued the work with this. So he could collect 349 patients because he was very enthusiastic. So he used to move to the pediatrics every day. So then he classified as per the WHO criteria, severe, very severe, and very, very severe, like that. And then they started looking for RSV as well as metanimo, because the metanimo was coming up those days. It was started in 2011 and then gradually it was picking up. So he said, let me see these two things. Looked into it. He looked for the viral load, cytokines, and then see, this is way how he classified. And he could find 40% positivity of RSV, around 7% of human metanimo with some co-infections. This is expected to have it. And the winter months, you say January to April was the peak to get this positivity of these cases. When he was comparing, he could see that in case of RSV, you say MMP9 and TIMP1 mutation. MMP is a matrix metalloproteinase. What we saw is elastase damaging the matrix of the respiratory tract. So this matrix metalloproteinase, you are going to get increase in that damage that releases more of these things. So if you look into it in RSV, it is very, very high, significantly up high. And if you see interferon gamma as a good friend of viral infections, in case of RSV acute condition, the IFN gamma comes below, very low. So it doesn't give a protection immediately. If you compare that metanimo, usually metanimo don't have severe morbidity. So interferon gamma is better projected there. So that is expected to have it. Viral load, what we are seeing that in case of severe cases, definitely the viral load was more with a cutoff what we saw it. Now see, genotypes, how many genotypes we have? We have RSV sub A and B subgroup. In A, we have GA1 to 7, SA1 to 2, NA1, NA2, and ON1. Now, ON1 is the latest entrant to this RSVA. It was not there before. So it started entering in 2010, 9, 10, 11. So you see RSV, when it was categorized, RSVA 58, B18 of the total 76. Of the 58, 51, 7 stains, they became ON1. ON1, once it comes, it sweeps away. The previous Na1 stains, all those, they were being swept away by the ON1 stain. So this is the lineage what he wanted to show. Yeah. So there was evolutionary, the changes you say, evolutionary rate of the stain is 6.85 in 10 power minus 3 substitutions per year, gradually year by year, like 10, 11, 12. So the stains, they started replacing one by one. So this has got a 72 base pair duplication. That is what he basically wanted to show it. So this is the different stains. You say New Delhi, 2007, you look into 71% there were RSV-BA stains. Now you see that this is the study by Dr. Brewer, where she has shown that GA2 and GA5 group of RSV genotypes were prevalent during 2002 and 3. That's absolutely good, right? And gradually, the 2004-5, these 3, 2, and 5, they were interchanging between these two. Now, if you look into the combined effect in North India, the RSV circulation, you see 13, 14, you have, after sequencing, you had RSV-A 7 stains, ON1 6 and NA1 1. 14, 15, completely ON1. 15, 16, again completely ON1. That means ON1 started sweeping from 2012, 11, 12 onwards and replaced all those NA and NAB, all those previously circulating strains in North India. And at present also, whenever you type, it will be ON1. It is persisting. There is no much of change. Interferon gamma, it has been the severe cases we know, because they are not supposed to mount interferon gamma. If it is there, then that means it will be a paradox then. TNF alpha, severe cases, you have got very high values. IL-10, again, the same high values. IL-6, the same. They're all the markers, are inflammatory markers. They go with severity. That means they are the marker of severity. Now you do a interferon gamma, IL-10 ratio, usually you do for Th1 and Th2 subtyping. So you'll find that in case of those who are going to succumb, they will have a Th2 bias. Whereas those subjects who are going to recover will have Th1. That means they are not like they are the cell-mediated immunity which is going to take rest, so this is what basically Th2 bias means. It is detrimental for the patient. So it is IL-17. Now, the role of matrix metalloproteinase, particularly the study, it has what Dr. Subhabrata has shown, that in case of very severe cases, you have got much more. That means from acute to severe, acute will have less and the severe will have highest value. So this signifies that the case of MMP9 is going to have much more matrix damage or severity. This postulation, what he has put forth, he said when RSP load is low, then your ISG, interferon stimulating gene, is getting activated. You will have interferon production. Once interferon production there, you have IL-17 upregulated. So the person will have a Th1 response, have a better outcome. Now the reverse is true. Very high viral load, you will have Th2 response, which is going to have a worse scenario. The patient might succumb to it. Yeah. So that was the cytokine levels, different cytokine things. Over the time, the autophagy system started. So once the autophagy started, then one of my students said, let me work on that. So they worked on the autophagy. Now you see, once the autophagy genes are there, you are going to have autophagosome. That means degraded material are being engulfed by the autophagosome. Now this autophagosome is a vessel. It's an encapsulated vessel. If those things are to be degraded, then the lysosome has to be there. Now there will be a fusion between autophagosome and lysosome to give you a autophagolysosome. If you have a disruption in this, that means the disease is not able to be curtailed. So the virus will remain sustained. That is what happened with RSV. Now, in case of severe RSV cases, there was down regulation of mTOR, mammalian target of rapamycin. So the mTOR is usually beneficial. Now, once this mTOR pathway is suppressed, means autophagy is upregulated. Once autophagy is upregulated, there will be no phagolysosome fusion. So the RSV viruses will remain inside, there will be proliferation. So there will be a lot of viral load. So that finding has been proved it. So I'm just touching this because the other aspect, while before leaving these studies, I thought, let me touch the last part, like vaccines. So looked into it. What is the management? Management usually supportive, and ribavirin, everybody knows that is the choice and licensed antiviral therapy, but it has got its own limitations because of cost factor, toxicity, and also the age factor to whom you are supposed to give it. So this ribavirin, there are studies where people have also shown that oral ribavirin has a better clearance and no need of giving injectable things. So this way you have got studies. Now, besides that, we have immunoprophylaxis. This is the very common one, palivizumab, going on since years together. This is only FDA approved for severe RSV, lower respiratory infections. With specific high-risk pediatric population, this has been given. It has got a prophylactic use, and the efficacy is well established, but it has got other limitations. Now the thing came out that is short-lived. For a short duration, you have to give palivizumab. But for you want to cover a season, like a single dose covering one particular season, like 5 months, 6 months of that particular, then this nirsevimab is the monoclonal recombinant antibody, which has been now in phase 3 trial, and possibly it is going to give a better response. This is the way what they say that either you should have a passive maternal antibody transfer that is going to help, or like the palivizumab, what we are saying, long-acting antibody like nirsevimab, or you can go for a maternal vaccination during pregnancy. So you have to give 2 weeks before the pregnancy so that you can have the transfer of the antibodies from mother to the child. Why these people, they thought, why you have to give a vaccine before last 2 months? Because it has been seen that the titers of maternally transferred RSV antibodies decline very fast. Say 73% at 1 month and just 2% at 6 months. After 6 months, you don't have any antibodies of maternally transferred. So such a short-lived. That's immediately to cover a child soon after birth, you should give a vaccine to the mother. That is the concept. So 3 maternal vaccines, they are in clinical trial. One is Resvax. The other 2 are the RXV and Abriospo. So here we have the GSK and Pfizer, and one more is mRESVIA, that is Moderna. All this, it has seen that the 80% is the maximum protection, and over 6 months it comes down to 30-40%. So this is the as of now the available scenario. So my last student, PhD student, Dr. Bhartendu, just completed very recently. He started working. He said, let me work with the vaccine, because he had good at molecular techniques and cloning, all those things. He got trained from Dr. Narayan Rishi. So he was recommended by Dr. Narayan Rishi from Amity. So then I said, okay, then I'll put this into vaccines. That was a desire for me to go before that to have some sort of vaccine activity. So what he started, he looked into the RSV, F gene and G gene. And usually the F is, you say, for A and B, between A and B, it is 95% conserved with the genotypes also. Whereas G is hardly 32% you have got sharing. That means very hyper variable. The antibodies to G, they are not protective. They are just cross-reactive type. But F you got very beautiful neutralizing capacity. So usual target is being done for the RSP-F protein. So he started working with in silico mutational and stuff. So then by this time, we had the COVID experience, the pre-fusion component. So pre-fusion component, what appeared to be better than the post-fusion, because during post-fusion, there are many of the antigenic epitopes are being masked, and that becomes very rigid. So it doesn't available for good immune response. So the pre-fusion state, you have got better antigenic properties, but then it is very unstable. So you have to make the pre-fusion state more stable so that you can use that as a vaccine candidate with exposing all possible antigenic epitopes. So that was the concept where he started working with this in silico mutational stability analysis. He took the pre-fusion form of this F protein, started designing and generating structural expression of the VLP, then he characterized the VLP and then wanted to see the immunogenicity. So these are all unpublished data. So he's about to publish them. So this RSVF protein, so he did the mutations. He did with the F1, F2 subunit and blocks the upward HRV movement and formation of 6 heptide bundle. This is the structure where there are 6 mutations he has introduced, and the 6 mutations after introduction, he subjected to the molecular dynamics studies for this mutant as well as the wild type, and he could show that with such high temperature, 500 Kelvin temperature also, the mutants, they sustained the structure without much of change. So that is one of the component of study. And he also studied the stability analysis using fold X5. I don't know much about this, but still this is the way how people they start looking into, and they see that the mutant as well as the wild, how much of energy. So energy wise, you see that in case of wild, it is 117, mutant 97. Mutant should have a negative energy. So there is minus 19.41 kilocalories per molecule of energy. Because negativity shows that they are much more stable than the wild ones. So this is the finding what he was proposed it. Then started site-directed mutagenesis to get the primers. He did 6 mutants were created. Then once the F fusion matrix and phosphoprotein were introduced into the cloning vector, 293 cell line, and then there was good expression of this RSPF protein. First one, what you see, so then the VLPs were they were planned, they were expressed in this 293F expo cell line. Now purified through ultracentrifugation, then subjected to structural stability through electron microscopy. You see the structure. It gave around 328 nanometer size, very stable with the normal RSP virus. With F glycoproteins, they are expressed on the surface very, very well. And then again subjected to STS space to look into the pattern. So he could, by this way, what he said that he could develop good VLPs. They are structurally, this molecular dynamics wise, everything they found out to be very suitable. But unless you put them into experiment, you cannot say that. So this is the last thing, the putting into animal system. So we got the permission to use biopsy mice. So he took biopsy mice, 3 doses, 10, 20, and 40 microgram, 3 doses, 2 adjuvants, alum and adavax, 2 adjuvants, because one you say whether success or no success. So 2 adjuvants he tried to do. So he injected on day 1 and day 21, 2 doses, and day 42, mice were sacrificed. Day 21 and day 42, twice it was bled. And then the mice, once sacrificed, the spleen and the lungs were taken. and spleen, it was for the antibody secreting cells. That was the point to see that how much it has been secreted. So now the serum, they were subjected to ELISA, good ELISA titers, but that ELISA titer, it was better with boost and alum adjuvant. And 10, 20, 40, there was no much of change. So we thought 10 microgram will be better because you are consuming less VLP than that way. So with 10 microgram with alum with booster second dose, it gives a very good titer. That was compatible and that. Now antigen secreting cells from the spleen also subjected and also gave the similar type of response. But that was antibody. How do you know they are protective? They may be cross-reactive. So he said, let me start learning to do a neutralization test. The other alternative for the neutralization test was the surrogate virus neutralization test, the lentivirus neutralization test. This was going on, Professor Ravi knows, with our DBT project HEV. So with Trishti and AIMS. So the AIMS was doing this neutralization test for the HEV virus clone. So then he started learning it and he did it. And after that, he could show that they had a good neutralizing virus in out of this. So then whatever the lungs he had, when he subjected to histopathology, he could say that the alum component have no reaction or minimum reaction than the Adavax. So in all this through, he said that if at all you have to go for a vaccine, VLP, F protein, then with alum and 10 microgram VLP, possibly we are going to have some, you can say, promising results. But this is a in vitro type. Now you want to do it, you have to wait for a animal model, or you have to look for other methods to say that this vaccine can be a good candidate. So this way, how the things it went on. So this is what basically the total activity or work done during last decade, 10 years. The respiratory viruses, then the plethora, the paradigm shift, the pandemic effect, and then the pathogenesis of RSV, and then lastly a vaccine candidate. Possibly this, if somebody wants to work on it, then maybe it may be useful to it in future. Thank you very much for giving this such a time for me and being with me for so long time.
Thank you, Professor Rato, for that wonderful journey.
This is the thing which I forgot to say. Yeah. Okay. So the contributors, I was supposed to thank the contributors.
Yeah, here we have.
Dr. Suabrata, then Dr. Bhartendu, then we have got the co-guides, all those co-guides, they were involved with it. The ICMR, DST, they have supported the work. So for all those, I'm really thankful to them to make these studies successful. Thank you. Thank you very much.
Thank you so much. That was a wonderful exposition of a neglected virus, which is now becoming priority, all the way from basic virology to immune response and then to protection. I'll request Madam, one of our senior most virologists who has contributed to this field, to give her comments. Madam Shobha Broor.
I am very nostalgic at this moment. I being an alumni of PGI and being in the Department of Virology in the very early years, this is a opportunity I should not have missed, and I wanted to be there, but somehow due to some family issues and my daughter being not well, I could not leave the town. Anyhow, I want to not say much, but congratulate Dr. Rath for this excellent work on RSV. Very few people like me work on RSV. They think this is not an important virus. But now it is also being recognized as an important cause of respiratory infections in elderly. And the two vaccines which have become available, the Glaxo and the Pfizer vaccine, are both licensed mainly for adults and maternal vaccination and not for children so far. So your attempt at developing a F-based vaccine for RSV using the VLPs may be a very good attempt at having a new vaccine which can be given to children rather than just to adults. And I congratulate you for that. And I'm very nostalgic at this moment. And I want to congratulate you. And may you have a very happy and prosperous life even after leaving PGI. Thank you. Thank you for giving me this opportunity.
Thank you very much, ma'am, because I'm seeing you here and I'm remembering everything. We had a lot of good times, and we
Yes.
had that we stayed together in Srinagar and all this. That was the last time we met, possibly.
Yes, I know. I wanted to be there for you and for being in PGI, but my daughter is having some issues and I'm looking after her here in Delhi, so I could not leave the town.
Yes, ma'am. We are missing, ma'am, you.
No, at least with this technology, we could see you and
Yes,
hear
yes.
you.
Yes.
That is actually some good things with high technology.
Yes,
Don't know.
I've been listening to since morning to all the talks and enjoy Dr. Ravi's talk also. So it has been a great day for me that way. Thank you. Thank you very much.
Generally, for a plenary lecture, we don't have questions. It's almost his lifetime work that is presenting. So, want to congratulate Dr. Rato, and as Madam said, on behalf of all of us, we wish him a great second innings in your profession, and wish you good health, a lot of happiness. Thank you very much for all your contributions.
Thank you, sir. Thank you very much.
Thank you.
One more thing, Dr. Rato. Sir. I used to attend many DBT meetings, and PN Tandon used to be very aggressive. Why don't you talk to industry first before you talk about vaccine?
Exactly, exactly. That is the.
So that is, I think, next step probably will be
Yes.
some, because high impact factor journal publication stands in the book and volume 160, page 390, and that's the end of it. But I think to move forward, at least make an attempt, something whether it will be successful or not is a different story, because industry perspectives are entirely different. The volume, the titer, the enhanced large scale preparation, everything. But at least make an effort so that we can move forward later.
I think that's the best suggestion, sir. I think that should be done this year.
Thank you.
Thank you, sir. Thank you. Thanks, Dr. Mini, giving such an opportunity. Made me very simple, giving a plenary lecture.
Thank you so very much, sir, for that remarkable plenary session and a walk through the memory lane. It's always a pleasure to hear how nostalgic you get when you talk of the department and how you brought it up from one room, two rooms to a full-fledged department. And we're blessed to have a person like you to guide us further, sir. Now, may I request our esteemed chairperson that as a token of appreciation, will they please come forward and felicitate our speaker?
सर आप दोबारा देखिए फोटो नहीं हुई सर
May I now request Professor Ratho and Professor Mini P. Singh to kindly felicitate our chairpersons? Thank you, sir. Thank you, ma'am. अच्छा सर बात
Very high connections, get two permitters.
Good afternoon, everyone, and welcome back. I hope that you thoroughly enjoyed your lunch. Well, I must admit that we have now arrived at that notorious time of the day when most of us are negotiating with our eyelids. But then, let me assure you, the session ahead is gonna be so engaging and fascinating that I dare say those eyelids won't have a chance to droop one bit. On that note, let us begin with our next session entitled Changing Landscape of Key Arboviruses in India. To chair this session, it is my privilege to invite our first chairperson, Professor Rita S. Mani, Head of the Department of Neurovirology, NIMHANS, Bengaluru. Ma'am is a distinguished neurovirologist and, by her own admission, has spent decades in stalking, interrogating, and outsmarting some of the most formidable viruses known to science. Next, I would like to invite Professor Sanjay Verma from Department of Pediatrics, PGI Chandigarh, and a distinguished clinician whose contributions to vaccinology and vaccine preventable diseases continue to advance child health and public health in India. May I now request Dr. Bajanti Mala Mishra ma'am to please come on stage for her talk. And may I also now request our respected chairpersons to kindly introduce the speaker and initiate the session.
Okay, so good afternoon, everyone. So over the past 2 decades, we have seen expansion of arboviruses. We have seen expansion of dengue all over the world. Almost half of the world area is now affected by dengue. Recent outbreaks of chikungunya recurrently occurring and emergence of Zika. And now we are also concerned about JE and other arboviruses. So what is actually changing this is not very clearly understood, whether this is climatic change, it is urbanization, globalization, or how this is affecting. I think this is what we need to understand. And secondly, the vaccines are coming up now for dengue vaccines are there. Takeda is going almost on the verge of getting clearance, and this 2 more vaccines by India by Serum and this one more by Panacea. They're entered into the phase 3 trials. So I think this is lot more is happening in this area. And to know us now, let us know more. We are going to have this talk on changing landscape of the arboviruses. And Madam, you can introduce.
Yeah, so Dr. Baijantimala Mishra is, she needs no introduction in this particular audience. She is a former faculty from PGI, and I feel she is very much a part of the PGI family. She is a professor and head of Department of Microbiology at AIIMS Bhubaneswar, and she's also Dean Research at the same institute. So we look forward to a very engaging talk from you, Dr. Baijantimala. The mic is yours.
Thank you, Dr. Rita Mani and Dr. Sanjay. And of course, I must give a big thank to Mini for inviting me and giving this opportunity for this talk. Thank you, Mini. So this actually podium makes me quite nervous. This is our CPC hall, and we used to give like virology clarification to the whole full house for all CPCI. That days are coming in my memory. Anyway, so coming to the topic, changing landscape of arboviruses in India. So arboviruses, as the name suggests, these are derived from arthropod-borne virus, which refers to viruses transmitted by humans by the bite of arthropods such as mosquitoes, tick, and sandfly. And these are though found worldwide, but are common in tropical than temperate climates. And though there are more than 500 arboviruses, there are around 100 are known to cause disease in humans. Now, these are some of the important arboviruses in India. We all know the names of this transmitted by mosquito, tick, and sandfly. And why these arboviruses are important? Because they cause severe disease with high mortality like hemorrhagic fever, encephalitis, then the spread of transmission, like they keep on expanding their tentacles to the geographical expansion, then emergence and re-emergence of pandemic potential of a serious global public health threat. And in India, we keep experiencing outbreak of arboviruses like dengue, hemorrhagic fever, chikungunya, encephalitis, by Japanese encephalitis, and then CCHF, Chandipura. These all are like keep us all on our toes always. Now, the most dear of all of us, the dear dengue. So dengue has emerged as a major public health challenge across the globe. Around 4 billion people are at risk of dengue infection. As you can see, that band, the entire band is at risk, which accounts to 400 million people get infected every year, and reported number of dengue cases has increased from 5 lakh, which was in 2000, become 5.2 million in 2019. And majority of them are in from Southeast Asian countries. And this shows the contribution of India in Southeast Asia dengue cases. You can see over the years how it has come from 6% to 44% contribution from India only. And this again shows how the cases are rising starting from 2000 to 2019. And again, like this again shows the geographical expansion also, where you can see how the states are becoming more and more involved and also darker and darker. That shows the more and more endemic those states becomes. And again, further from 2013, it keeps expanding. So dengue again has also been like which we used to read that it never occurs, mosquito-borne disease never occurs in hilly areas. That again it proved wrong. It has been reported from Himachal also. Now the situation what was 8 states in 2000, by 2019 35 states are involved, and including the high altitude states. And this again shows you can see the left side from 1996 when we had the first major outbreak of DHF to 2011, which shows the cases around 2000. And the right side graph, you can see if you take the baseline of 2000, again, how the cases are increasing 10 for almost 20,000. And again, this shows how it is expanding and more states are becoming endemic and hyper-endemic. Now, the serotypes. Now, serotypes in dengue, now in India, all the four serotypes are circulating. Now, when this serotype or we experienced this dengue came into limelight, the thought what came to all of our mind that whether any particular serotype or genotype is responsible for the outbreak, or any particular serotype is responsible for the severity. So there are many studies, these are just few of them, many studies from many of us, like we kept studying that which is the culprit dengue serotype. And ultimately, what was found from all of this study of many virologists, that at one point of time, one particular serotype is predominant, while other serotypes are less prevalent. And over few years, the predominant serotypes gets replaced with another serotype and becomes less prevalent. So this keeps like circulating. Now, then the co-circulation. Now, co-circulation, like we had reported from Odisha, the co-circulation of all 4 serotypes in one season, and there are many similar types of reports from other parts also. And now this is the 2021. You can see almost all the states are showing co-circulation of serotypes, and this is the recent one where from north, south, and various parts of India, you can see all the 4 serotypes are there, and the country picture is also there, where you can see the right hand side. You can see in a much prominent manner that it is the dengue 2, which is most prevalent, followed by 3 and 1, and yes, 4 is also there. 4 was almost, we never encountered 4, which is again become a reality. More and more reports of 4 is also coming up. Now, this is a seroprevalence which again depicts the hyperendemicity of these areas, particularly southern, western, and northern states. And if you see the age group affected, it has been seen that the dengue, which used to be predominantly a children disease, now that is decreasing probably, and or maybe more appropriate would be the adult group are more getting affected. And the maximum cases amongst the age group is 16 to 45 years. That is the most common age group for dengue now. Now, again, dengue we used to know for as a cause of fever or hemorrhagic fever. Now it's now from unrecognized, what Ravisha had first brought this virus to limelight as a cause of encephalitis. Now it is almost an established cause of encephalitis, acute encephalitis. Now, moving on to this chikungunya virus. Now, this is again a very interesting virus. Now, if you see from this picture, now from 1963 to 75, there are several epidemics were there, and this virus went to hibernation till 2005. It was completely asleep like Kumbhakarna. Then all of a sudden in 2005, there was an explosive outbreak, not only in India, also in other island, many other islands. So there was a re-emergence of this chikungunya, which we used to read as just a name of virus. That's it. And from 2005, for our generation, it came up. And this picture, again, you see from 2005-6 to 2011, this virus is again fading away. And even the title also tells so, the beginning of the end of another episode. Now, when this was the picture, now look at this. Again, the re-emergence of chikungunya. And again, it is keep on expanding, and re-emergence keeps occurring. So in chikungunya, if you see again this graph, how the graph is declining, and again see this, again it is increasing. So this is a very interesting virus. Now here you can see some in between faded areas, and again the red color becomes more and more like this. So all this dengue and chikungunya, because of various reasons like urbanization, globalization, air travel, these frequent epidemics or frequent outbreaks and increasing number of cases are occurring. Now, this was the major vector for these two. Now, this one appeared, came into picture. Now, what was the problem with this? Now, this albopictus is exophilic in contrast to Egypti, which is endophilic, and this is more adapted to not well adapted to urban environment, but better adapted to cooler climate, so temperate climate, northern and northeast states, and contributes to expansion of dengue. And so why this vector is so special, that it has colonized both in tropical and temperate region, and it is identified in temperate climate like Europe and North America, and currently in several European countries. It survives both rural and urban, and it has adapted to peri-domestic environment also. So this also contributes to the re-emergence of dengue. Now, dengue, which was very typically known as urban disease. Now, there are many reports from village also, this dengue is getting reported. So there's a paradigm shift. It's not that it has gone from urban, but it has started encroaching the rural areas as well. Now, as far as this vector is concerned, now for dengue, it is albopictus is playing the role for increasing and expansion, whereas in chikungunya, it's a very complex interplay between the virus and the vector because of this re-emergence and quiescence. Now, how it does? Now, if we see this, now this occurs due to combination of virus mutants and along with the specific vectors. Now, if you see this with Aedes aegypti, there are certain combination, it has been shown, there are certain combination of mutation of virus, and with albopictus, again, there's certain set of combination of mutants, and this combination of mutant virus with the specific vector, when it occurs, that increases the infectivity, that leads to higher transmission, persistence, and epidemic drive. Whereas, then why quiescence occurs? Now, quiescence occurs again for the same reason. The set of mutation, particular strain, in particular strain, that blocks the adaptation. And that possibly leads to control the frequency of epidemic and periods of quiescence. So in chikungunya, the story is very different from what it plays the role in case of dengue. So this is how the vector and the virus interplay, how it determines the outcome of the disease. Now, this has been a report from 2010 and 16 outbreak in Delhi, where it was found that you can see in the 2010 outbreak, the clinical and viral load was much prolonged as compared to the 2016 outbreak. And it was found that majority of the isolates in 2010 actually had some mutation which hinders the neutralizing capacity, and they're associated with typical manifestation like arthritis and increases the pathogenicity. So this was like chikungunya outbreak in dengue. So this mutation plays a very important role in chikungunya. Now, as far as the seasonality is concerned, yes, seasonality, the typical post-monsoon and winter applicable for dengue and chikungunya both, whereas what we are seeing in dengue is slight seasonal shift. Though I think many of us will agree with me that dengue also we are getting throughout the year, whereas we never used to see even a single case during the off season, whereas it's almost perennial. The NS1 is coming positive, the PCR is coming positive, though yes, the seasonal peak is there. Now, moving on to this new virus, relatively new, but in India, it actually dates back to 1954, where the seropositivity was shown, and that was mostly from the Gujarat state. And in 2016, November, the surveillance was started for Zika, and 17, the first case was reported. And by 2024, there are several outbreaks in several states of India. Now, these are the viruses I'm going to deal with by Culex mosquito. Now, this is a recent study by this ICMR taking the VRDL networks data. You can see the Japanese encephalitis status from 2014 to 2023, how it is expanding, how the cases are increasing, though there are some peaks in 2019, but it's always a rising trend. And this again shows the difference from 18 to 23. Now, this just to show how it's happening in Odisha, the expansion, geographic expansion. And this is again the shift in the age group, we can say. Predominantly, it is 10 to 20 years, but in some areas, it has been shown that maximum in 30 to 40 years. And this is again from our data, where again 11 to 20, we are getting maximum cases of JE positivity. And if you see the Culex abundance from in different season, and we can superimpose this J cases, it will just fit to that. Now, this is very interesting. The pig plays a very important role in J. It has been isolated from various states, PCR positivity, seropositivity, and probably why it is coming to urban area, mostly because this pig population in the slum area, which you do not get any official documentation. Like when I personally inquired, they say, "Ma'am, जब उनको पता चल जाता है टीम आने वाला है, pig भगा देते हैं." So this is the picture of why it is. So J is becoming from rural to urban. Now West Nile, yes, again the cases are increasing. What is interesting here is West Nile. There are two lineages which are seen in India. Lineage 1 is mostly in South India, and lineage 5 in Northeast India, where this virus is most common. And lineage 1, if you see very interestingly, it is associated with the ocular manifestation, whereas lineage 5 is associated with the encephalitis. And this ocular manifestation, if you all remember in 2012 in Tamil Nadu outbreak, the retinitis, Western virus causing retinitis. And I got a very beautiful picture. It causes multifocal retinitis. And though in the upper part, you can see Western virus affects various parts of this eye. So this I found very interesting as a clinical picture. We never used to realize that this virus can cause ocular manifestation, and that to retinitis. Now these two, tick-borne disease, always like ticks are associated with the forest. When you go for some or other cause and handling with the animals and KFD, mostly with the monkeys, the person acquires the infection. This is mostly in the west part, CCHF is seen. And when it started in Ahmedabad, and now it has been reported from Rajasthan, Maharashtra, and some other positivity also has been seen from the adjacent states. So you should be very careful, because CCHF is a disease where the blood is infectious. And it's a very important risk factor for the healthcare workers, the family members. Like, though I should not say like it's as infectious like Ebola, but yes, like unlike other arboviruses, the blood is infectious, though the person first takes the infection from tick, but human-to-human transmission can occur. The unfortunate thing, what I was surprised to see this from October 2025 NCDC report, every year we are getting some or other cases and deaths due to CCHF. Now, seasonality, again, mostly it is like July to September. And this shows very interestingly, though it is mostly confined to the Western region so far, the risk map has shown some southern states also. So we should be very careful that probably they are also under risk. Now, KFD, again, it is spreading. Very typically, we used to read that KFD, Kasnur forest, is in Karnataka. And now look at the picture. It has spreaded to all the adjacent states from like Karnataka to Maharashtra, Goa, and Gujarat, and down below Tamil Nadu, Kerala, all are affected. So that is something like the tick-borne and getting spreaded all over. Now, this is a recent concern. And this virus, people were not accepting as a pathogen till this paper came by NIV, that as Chandipura virus as a cause of acute encephalitis, when they isolated the virus and showed the electron microscopic picture. And this was isolated in 1965, but it came to limelight in 2003-4 when the outbreak occurred in children in Andhra Pradesh, and 2003-6 multiple outbreaks occurred in 2024. Again, the outbreak occurred in Gujarat, leading to case fatality more than 30%. So this is now an established cause of encephalitis, and very pathetically, the fatality rate is very high. And so many states have already been reported Chandipura from their states. Now, diagnosis, I'll just go very rapidly how the evolution in keeping dengue as the key one, starting from virus isolation to MAC ELISA in 2000, early 2000, when I was in PGI, the first kit, if many of us can recollect, this was the NIV kit of 3 days kit. The third day, we used to give the report, 2 overnight steps. And then the PanBio came, then NS1 came, that became the game changer for dengue diagnosis. Then, of course, the rapid came, then the molecular came, and we all moved on to molecular, the conventional, then RT-PCR, and now it's multiplex PCR, and probably in future we have many other sophisticated molecular tests. And this conventional PCR, what we used to do for dengue serotyping, now it's all multiplex RT-PCR. For syndromic panel, again dengue, chikungunya, many of these studies are actually my PGI studies. Now by 2026, all of us have moved on to multiplex PCR. And this is the era of the syndromic multiplex PCR testing. But here I would like to say that please remember for these youngsters that this negative PCR does not rule out infection, because it's a marker of the it picks up the early cases. So please do not rule out if PCR comes negative. That's very, very important. Now, this is a very recent paper in June of this month, IJMR, where the NIV group have come up with a real-time point-of-care test for Castor disease, because this is also a disease with high fatality. And what I found that with excellent 95, near 100% sensitivity and specificity for this point-of-care test, which is developed by this NIV group. And this prevention for this arboviruses, these are the 4 pillars, which many of us already discussed: the vector control and vaccine, One Health, and public awareness. Vector control is mainly for mosquito and sandfly, and public awareness, of course, for all this, and vaccine for what we have for dengue, JE, and KFT, and One Health, mostly where animal is involved. And vector control mainly based on these 3 principles: elimination of breeding places, avoidance of exposure and larvicidal measures, and public awareness, wherever like public should know what all like symptoms are there, whether vaccine is there or not. This is important for each and every arboviruses. And very important, wherever tick-borne disease is there, how to avoid the tick bite, that they should know. And coming to vaccine, dengue vaccine, I'll talk only about dengue vaccine. What the first WHO licensed vaccine, TDV, which is the tetravalent vaccine, is almost the story of the past, because once the manufacturer announced that there's a chance of adverse effect if there's no previous exposure, WHO came up with the dictum that screen and vaccinate, which is practically very difficult. So that has really restricted its use. And now what we have is Qdenga. The limitation is, again, the age is 6 to 16 years and high prevalence area. And of course, with multiple doses also required. And what we are hoping for the future dengue vaccine, we all are hoping for that, which is by this Indian company, Panacea Biotech, and maybe some other company. And phase 3 trial is going on in collaboration with ICMR. And probably that will solve majority of this dengue problem, because here it is meant for 1 to 60 years and single dose. And if that will become successful, that will really be a boon for dengue to manage the dengue cases. So I'll just summarize. For all the arboviruses, increase in number of cases, expansion to new geographic areas, spread from urban to rural in case of dengue, and rural to urban in JE. There's a paradigm shift in age group from children to young adults in dengue and JE particularly. New clinical entities for dengue as AES cause and West Nile as a cause of ocular manifestation, role of vector and virus, particularly the albopictus, which is more adaptable and responsible for re-emergence of dengue, whereas the complex interplay between the vector and virus is responsible for the re-emergence and quiescence and virulence of chikungunya. Diagnostic, yes, serology and PCR are still the mainstay, but yes, we are also living in the era of syndromic multiplex panel testing and point of care testing. And prevention, we all are hopeful for a successful dengue vaccine in near future. Thank you.
Thank you, Dr. Mishra, for such a wonderful overview. You tried to cover such a huge topic in such a small time. Thank you for that. But what I personally think is that now thinking about managing these arboviruses, we need to move about anticipating when the next outbreak is going to happen and do something for that. And when we poorly understand why this is expanding, it is very difficult. And the vaccines give some hope. Like the JE has made a dramatic difference. 4 or 5 years back, we used to see so many cases of JE coming from Haryana and this belt. And now hardly any cases of JE we are seeing. And this dengue, like you said, this new vaccine, this Qdenga has come up. So we need to keep this surveillance of this serotypes. Means what is
Qdenga is not it's not in India.
No, Qdenga has recently got licensed in India because a subject expert committee has given clearance.
Okay.
So maybe in next few months it is going to come. And this Qdenga is basically a Takeda vaccine.
Yeah.
And this is mainly against the type 2. So this is showing very good response against type 2. But type 3 and type 4 response is not that good. And we are even anticipating more adverse event if 3 or 4 are there. So that kind of a thing is there. So it is very important to see means what strains are circulating. That is what.
Because in dengue, the strains keeps changing.
Yes,
the circulating strains
so
keep
regularly
changing.
we need to keep a surveillance.
Continuous molecular surveillance is definitely mandatory.
So we can take up some questions if there are some. Yes, please.
Yes, please. Mostly it is because of the antibody dependent enhancement, because the antibody is already there. So what happens when you are infected with one particular type, that type, the antibody is produced against that type and also to other types. But to other heterotypic types, the amount of antibody is much less. So what happens over the time, it gets waning occurs. So when the next infection occurs due to some other serotype, you have antibody of subneutralizing amount. So that subneutralizing means it can bind to the antigen, but not able to neutralize it. So by that, what happens? Now it has captured the antigen, but not able to neutralize. But so that binding has the receptor to macrophage, which is the target cell. So it facilitates in a way the entry of virus to its target cell. So that is why it is called antibody dependent enhancement, and that leads to all further. Of course, it's a more viral load, more of cytokines. NS1 also plays role. It is multifactorial, but yes, ADE plays a major. That is I think you were asking for.
Hello. Yeah. So we, in this era, when we are talking about everything related to immunity, we knew it, but now after COVID-19, so we have much better knowledge about the immunity, whether immune exhaustion or immune activation. So is it the immune exhaustion or immune activation in the second or third attack of dengue? Of course, the serotype we don't know unless until we type it. Whether most of the times we are doing it in our department, I mean in virology department.
Yes, that is serotyping is not to see this immune response.
Yes.
But usually the antibody which is produced by the homotypic antibodies are longer lasting. That gives a robust immune response for a long time. But for the heterotypic strains, this you can say immune exhaustion. That gets, decreased and not able to neutralize it.
Neutralize it. Okay. Yeah. Thank you.
So that's
I think I got my answer.
Yeah,
Thank you.
we'll take one last question, Dr. Gadkari.
A long time back, there was a paper published in Science, and the US university studied dengue in Nicaragua for 13 years. Each and every patient was followed for 12 years. And what they found was, what Dr. Mishra said is about a Halstead theory, antigen antibody non-neutralizing taken up by the macrophages with the Fc receptor, and the virus becomes macrophage tropic, and then the DHF, DSS, whatever it is. What these people found was the antibody titer. So if we have a lot more antibody titer, second infection doesn't matter. It is cross-neutralized. If the antibody titer is too low, second infection is considered as a primary infection, there is no enhancement. But there is small band of antibody titer, which is really, they call it danger zone. And that is what this procedure, this immune enhancement occurs there. And so that was a way, and that makes sense to me, because if you see in India, multiple serotypes are in the same community. So you're getting re-exposed. But do you fall into that danger zone of antibody? Those who do, then they might come with the DHF, DSS. Otherwise, it's neutralized or considered as a primary infection.
A lot of heterogeneity is there, as well as response for this immune enhancement, whatever we are talking about. Because some people even getting infection twice or maybe thrice, they survive. But some people getting even first time or maybe second time, they don't survive. So we lot of time, why I'm saying so, we get autopsies and we don't know the answers by looking at the morphology alone. So we need to, probably go at the molecular level and immunity level. So to look into these aspects which have been highlighted. Thank you.
Yeah, so that was a very interesting discussion. For want of time, we need to stop here. I thank on behalf of the co-chair as well.
Thank you so much.
Dr.
Thank you.
Mishra, for a very insightful talk and very good slides to go along as well.
Thank you.
We also thank Dr. Mini for this kind invitation. And both of us congratulate Dr. Ratho for a very long and successful tenure at PGI and wish him a very happy, healthy, and peaceful post-retirement life. Thank you.
Thank you, ma'am, for that insightful and thought-provoking presentation. We sincerely thank you for sharing your expertise and valuable perspectives on this topic. As a token of appreciation, may I now request our esteemed chairpersons to kindly felicitate Vijayantimala ma'am. May I now request Professor Anita Desai to please felicitate our chairpersons.